to join names. And even after that, I keep on coming. And Professor Rajan Kumar is here, so my association with my alma mater is always there. So whenever I come, I give a visit to the medical college and give a small talk with interacting with a resident. That's because I have been teacher throughout my life. So this topic, which has been given by Director and Head Dr. R.R. Sinha, is talk about the diagnostic dilemmas in rheumatology and arthritis, he said. First dilemma is what is rheumatology and what is clinical immunology. A lot of confusion is there. So that's why when you look at the chairperson, one is rheumatologist, another is physician, rheumatologist, another is orthopedician. So what is rheumatology? Everybody keep on saying has to do with rheumatoid arthritis or joints. Oh, no. What is clinical immunology? Everybody says it's easy to define cardiology, neurology, gastroenterology, but when you look at my specialty, I'm internal medicine guy, is clinical immunology and rheumatology. Clinical immunology, take any disease, that's a clinical immunology. There has to be autoimmune phenomenon going in your body. So in rheumatology, just believe me, I keep on telling to my resident, it has nothing to do with joints. Looks very absurd. Nothing to do with joints. Joint is one of the system involved. It involves every part of your body, including your eyes, heart, lung, tummy, whatever you say, kidney is most common for us, and skin. But the patient complain when they start getting pain because joints is involved. So they come. Unfortunately, rheumatologists in India are very few. You are lucky you got few rheumatologists here. Otherwise, where they go? They go to orthopedics, my colleague, Dr. BP Singh, and others. They will see joints. But the problem is, joint is just one system. Others we are missing. I'm going to just tell you about how to approach here, to look at the dilemma. So everybody understood, rheumatology doesn't mean arthritis all the time. My OPD is only 50% is, because that's the most common symptoms patient got and referred. But 20% is from the eye department. Cardiologist, myocarditis you look at, lung fibrosis, myositis, all these are part of clinical immunology and rheumatology. So huge. So question comes, who is going to be the rheumatologist, internist, who can examine all system? I've been at AIMS, I was faculty in Department of Medicine. Got an interest in rheumatology, so we developed both. So any physicians got a common sense, are practicing, can become a good rheumatologist. And to become a good rheumatologist, you have to be a good physician. You have to use your stethoscope, don't leave it in the almirah. Look at the chest, pericardial rub, pleural rub, you got a lot of many things. Despite having rheumatoid, lupus, these things management change. So with this, I'm going to proceed. This should be coming here. Right. So first slide, you're going to present there, no? Right.
This will get you front, this will get you back itself.
That's okay. So look at this. My topic is rheumatoid, so I'm going. When you're diagnosing rheumatoid at this stage, it's already known from a distance, no points. Your job is, as a clinician, to diagnose rheumatoid at this stage when they looks like my hand and your hand. Why it's important? You diagnosed at this end, whole life you will have normal hand and not giving the pleasure to my orthopedic colleague for operating. Normal hand. No way we can cure at the moment. We can 100% control these type of diseases. 100%. Now, but all the hands are not. Look, This X-ray I have shown, hands picture I have shown you, 6 months after joints pain, deformities start coming up. So in cardiology you got a window period, neurology you got a window periods for CVA. Here you also got a window period. You catch them early, treat them, whatever medicine you want to use. I'm not going to debate, but catch them, treat them. Otherwise they will start developing deformity. But not all the hand joints are rheumatoid. This is osteoarthritis. You start getting nodules also here. I think it's not seen here. So you start getting nodules. It's a very early nodal osteoarthritis. So all the hands are not rheumatoid, just remember. And catch them early. Now this is my master slide I keep on showing to all the resident. Rheumatology is so easy specialty. Use your common sense. And most of the 95% of diagnosis is based just on history and clinical examinations. 5% where you need investigations. And those investigations give you more confusion than helping you out. So when you diagnosed clinically, whatever diagnosis you have made, rheumatoid etc., you have to stick. Whether this is a rheumatoid seropositive, sero, that's a different thing. So this is just to introduce to the subject to understand it's not joints all the time. You look at the other system. So now I'm coming to the dilemmas, looking at the cases, which is easy because it's a mixed crowd. So look at the E. First, giving you very simple. These cases I had taken from your clinic. You know these patients, I'm sure you can relate to one of your patients. 25-year-old female having a joint pain for less than 4 weeks. Early morning stiffness, 2 to 3 hours. History of fever initially lasted for 3 days. After that, joint pain start coming and is persisting for 4 weeks. Synovitis is present in, that's inflammation in the joints is present in both the wrist, MCP, PIP, elbow, knee and ankle. So is a polyarticular, 1, 2, 3 and many. Many is polyarticular. Rheumatoid factor is negative. X-ray of both the hands, which in the initial phase we don't expect lot of changes, no erosion is there. So what's the diagnosis here? Rheumatoid factors. You want to do CCP, you want to do other test, it's not going to help you. What you're looking for is there is a persistent synovitis in a young lady, polyarticular, bilateral symmetrical. So what should be your diagnosis? Oh, it started with fever, could be a reactive, possibilities are there. Seronegative rheumatoid, possibility, rheumatoid factor is negative. Maybe some connective tissue disease, in the early phase only joint symptoms and fever is there, no other. So what you're going to do? Very simple case, don't jump, don't start because reactive is still possibility. Oh. I think so what to do? If you are suspecting seronegative, must do ANA because you can catch connective tissue disease. If ANA is negative, don't bother about connective tissue or lupus etc. Still there is a possibility. That's you look at later. Only one test. Don't do it DS, DNA and other tests. You are wasting money. Just one test. Question is how you are going to manage. This could be a reactive. Reactive in majority goes in remissions within 6 weeks and 6 months 90%. So I will give only anti-inflammatory. Still lot of problems are there. Maybe giving dipomidrol and look for the persistent synovitis. Review after 2 to 4 weeks only. Don't start jumping. Still you are not sure rheumatoid. The reason message is very clear. The moment you diagnose rheumatoid started on methotrexate or any other drug, when you are going to stop, you are not going to stop. So before starting, be careful, make sure this is rheumatoid, this still can be seronegative rheumatoid. Okay, so this is one dilemma which I have given to you. I will not rush unless I have seen. So you look at 30% of so-called early seronegative rheumatoid arthritis is wrongly diagnosed as a rheumatoid by the rheumatologist, not the general physicians. Because we are rushing, can be a reactive arthritis. Okay, I'm clear? Don't rush. Unless you're 100% sure, don't rush, don't start. Once you started, you're not going. Don't give steroid, don't confuse the patient disease symptoms. Initiation has to be done whenever there is a persistent synovitis, at least I take for 6 weeks. When the majority of reactive arthritis goes in remissions, NA is negative, then you start. There are newer modalities doing MRI, etc., looking at the early erosions. Right. Now move to second patients. Go back to your OPDs and look at these patients. 40-year-old female, joints pain for 2 years, both knee, ankle, shoulder, neck, back, upper limb, early morning stiffness, 15 minutes I've written, going on for 2 years. Investigation has been done, rheumatoid factor is positive. Rheumatoid factor is positive. Lot of medicine has been taken, including desi medicine, which invariably is steroid. What you are going to do here? Very simple. Here, looking at your pattern, you are not convinced this looks like a rheumatoid because synovitis is not seen, and pattern is back everywhere. Back is not involved in rheumatoid. Okay, so what you are going to do is RF is positive. Your job is you stop the medicine, confirm the synovitis, and then only you start. Presence of rheumatoid factor doesn't mean patient got rheumatoid arthritis. If required, sometimes we do CCP. CCP is much more specific, but just believe me, unless patient got synovitis, I'm not going to start. You wait. Why you wait? Because patient has been taking various medications, and because of medications, disease is modified, mainly because of desi medicine, so that is steroid. Your job is to look at these features. Extraarticular features are coming up. Still not sure, please don't start disease modifying drug. These are little bit toxic drug, needs constant monitoring. One started, you're not going to stop. So what you're going to do in this type of scenario, maybe doing X-ray looking for erosion, etc. If you got a erosion, you start. CCP, which I explained, ANA looking for other connective tissue disease, only ANA, not more than that. Now I'm going to look at 40-year lady where you got generalized polyarthralgia. Believe me, metabolic cause has to be looked into. And the most common cause is still osteomalacia. Here, I may differ with most of the clinician. I don't do vitamin D. You do vitamin D of the people sitting here, 90% will be having low. So when your diagnosis is osteomalacia, you start looking at alkaline phosphatase, which is done in all the tests, routine test. If your patient is presenting like this, alkaline phosphatase is raised, then you do vitamin D along with PTH to diagnose. Okay? Otherwise, alkaline phosphatase, I'm happy, I will give vitamin D and calcium. That's you do it. It's a harmless medicine. Thyroid, please don't forget. Okay? This is very important where you can have a. But what's the most important? Anybody comes to me with these symptoms, I said, okay, I'm not sure, stop all the medicine, come after 6 weeks, 8 weeks, examine again, go through the history again, and then. Just remember, I'm not doing any test in any of these patients. What I'm doing is bedside, examine and making a decision. Okay? Now, here you got a message. Whenever you diagnose rheumatoid or polyarticular or any other conditions, synovitis is must. You are treating patient, you are not treating rheumatoid factor or CCP. You are not treating blood. So it's very important synovitis. So you stop the medicine, call the patient again, and then you document synovitis and you start disease modifying drug boldly. Now the third patients, I think I got time, 2, 3, 4 minutes. You got go back to again OPD. You will see this type of patient in your OPD. So I have not taken any complicated patient. 30-year-old lady, joints pain for 4 months, both hand, feet, knee. No history of skin rash, oral ulcer, is half time or something. Ulcer, alopecia, RP stand for Raynaud's. So I'm not seeing any systemic features or any extra-articular features, etc. Hemograms is normal, urine examinations. Only thing is ANA is positive. 1:160, which is strongly positive. 40 is okay, I may ignore. 160 is significant, but this ANA can be positive in whole lot of conditions. What to do? Lupus, ANA positive, joints pain, etc. If you still feel lupus is a possibility, one test I recommend, that's doing the ENA profile, looking at what type of autoantibody you got. ENA stands for extractable nuclear antibodies. Anticardial, lupus, anticoagulant, and beta-2 glycoprotein, etc. is leave it for the specialist to do it, because you are going to treat the patient, not the blood. Suppose ENA is showing you dsDNA is positive, ROLA is positive, send the patient to a specialist to make a proper diagnosis before you starting. In case all these are negative, how you are going to do? Very simple, anti-inflammatory review after 3 months, disease evolve. Unless you are sure, don't. Problem is, people are losing patients, doctors are losing patients, are starting at the first time, giving steroid. You give a steroid to anybody, they will feel better. But what's the long term? How long you going to give? And for what? So here message is, just remember, 5% of the normal population can have rheumatoid factor positive, ANA positive in the low titer. And this can becomes in elderly around 20%. So just on ANA, why you have done ANA, just think about it, why you have done, and if it is positive, what you are going to do should be very clear when you are requesting. Infections, even tuberculosis, drug-induced, INH can give you seroconversions, malaria, kala-azar, all these can give you ANA positive. So be careful when you are interpreting only ANA and no other features of lupus is there. Drugs, everybody knows, other connective tissue, so it doesn't mean just ANA got a connective tissue disease. Unless you are able to classify clinically, this is this connective tissue disease. Okay, now you look at these patients I have shown you. This is just to give a break. Rheumatoid, very simple rheumatoid, deformity, etc. is coming up. You look at in the second picture, the moment they keep the hand on the table, everything disappears. So X-ray I have put in the same hand, there is no erosions. This is a typical of lupus arthritis, where you got a JQ types of arthritis. There is no erosion. Here disease modifying drug is not required. You look at the underlying cause, looking at the system, you treat the lupus. Now, this is the most common, that's why I put one slide for you. You look at the 45-year-old man, banker, intermittent joint pain for 6 months involving knee, ankle, and the lower limbs only. And MTP is also, BMI is on the higher side, 28 we consider obese in our populations. Tenderness in the first MTP, uric acid is 9.8. First MTP is tender. This is gout? Nope. Still gouty arthritis is a possibility unless you see inflammation is there. Just remember, most common cause for the first MTP pain is still osteoarthritis, especially in ladies and obese persons having metabolic. And unfortunately, uric acid is also on the high side. If you feel like still is a possibility because the intermittent, ask them to come during the attack. You examine the hot red joints, and if that is there, do X-ray, ultrasound, or confirm it. Ultrasound shows very classical double contour sign, looking at the deposit of the crystals. Synovial fluid examination is a hallmark where crystal is seen, especially inside the macrophages. That shows acute flare. But what I am going to do in these patients, I will not start ULT. 9.8, I am not sure arthritis, there is no reason to start ULT. When they started ULT, it has to be urate loading therapy, it has to be again for long time. What is required is weight reduction, and doing exercise, uric acid will come down. This is not gout fitting it. So just raised uric acid, that shows your lifestyle more than I say gouty arthritis. Arthritis has to be there, then I will look at the uric acid, etc. Okay, which I have mentioned, so I will skip here. These are the polynodular gouty arthritis. These are seen in polyarticular. Always look at the kidney, you may find crystal, etc. You have seen these are, and this is very classical. You look at the first MTP. Whole bone looks like a malignancy is coming up. But when you look at the soft tissue, moth-eaten appearance, you can see calcifications, you can see. And when you examine, you will see the gouty arthritis. Another story, especially prevalent in this part, is the ASO story. 13-year-old male child, joint pain for 9 months, early morning stiffness for 1 hour, synovitis, both raised MCP, right and left ankle, right knee and left ankle. Everything is okay, but ASO is very high along with CRP. And the diagnosis is written, rheumatic heart disease, echo, etc., etc. Look at the 9 months. Persistent synovitis is going on. This is nothing to do. Don't do ASO. That confuse you. If you got a very clear cut, there you got an intermittent type of joint symptoms coming. A persistent synovitis. This is GIA. Rheumatic fever? No. GIA? Yes. Polyarticular GIA. 13-year-old. Here you are going to start disease modifying drug. Don't wait. Don't wait for ASO to come down. Don't do ASO. That will confuse you more than giving you any solutions. Okay? Rest of the treatments is for the steroid we give as a breathing therapy, etc., etc. CRPs. Many people feel CRP means arthritis is going on. This is wrong. ESR, CRP, these are just marker of inflammation. In many situations, CRP may not be raised. Like in lupus, you don't expect. Polymyositis, ESR is high. In fact, CRP we see much more common when infection is creeping and when you look at the corresponding ESR. So just CRP, don't do it. 600,000 rupees for simple any inflammatory markers is good enough. Persistent synovitis, polyarticular is very rare in tuberculosis, so please just remember that message. I think this is one last patient, if time permits, because bell I have heard. Right. 48-year-old businessman, low back pain, both knee, ankle, occasional hand pain, early morning stiffness, 30 minutes, no seronegative features. Seronegative features we say in seronegative arthritis, any psoriasis, oral ulcer, bloody diarrhea, etc. we look at. Eye involvement and oral involvement. Brother is having ankylosing spondylitis, no synovitis. Somebody has requested HLA-B27 which was positive because brother was having, so chances are is having. And lumbar flexion is limited, which can be seen in both mechanical as well as inflammatory. ANRF somebody has done which is negative. AS possibilities are, then you do simple X-ray. X-ray of pelvis. Look at is it radiological or non-radiological. MRI, if it is required, leave it for the. Here what is happening is people are getting MRI first and then doing the X-ray. You are wasting money. Review for documenting synovitis and anti-inflammatory. Only anti-inflammatory. Whether this is AS or this is mechanical, treatment remains only anti-inflammatory in the first go. So why there is a rush to start doing MRI and so fancy drug, including bone scan, etc., etc. Please don't do it. HLA-B27 itself got a very limited diagnostic. Unless clinical picture is suggestive, I will not give a lot of money. Why? In Indian population, 4 to 6% of population will have HLA-B27 positive. Not everybody is developing. So just doing and putting that money, this is marker. This is good when you got a clinical feature because prognosis changes when HLA-B27 is positive. Right. So this is typical of AS patient, just to show you. Measurement, Schobers, everybody knows, just to remind and flip you. Right. This is again the quiz. Any medicine people like to make a diagnosis. Here, just showing you one X-ray of the picture of this man, where you are seeing very clearly something has been done. So probably synovial biopsy because inflammation is there. Anybody likes to make a physicians or maybe surgeon second. So here the catch is inflammatory arthritis, everybody agrees. So when you look at, there is a clubbing coming up. You can look at all the fingers, there is a clubbing. If a clubbing is there, synovitis is coming, which is in the lower limb. Here we send the patient to the gastroenterologist. Patient got ulcerative colitis. Because enteropathic arthritis I am looking at. Okay. These are the X-ray where you can see these are SI joints we look at. Again, whole SI joints is fused grade 4. MRI you can see, this is just one sequence just to sensitize what we are looking at. Alright, this is one slide on the connective tissue disease. 20-year-old female, recently married, got Raynaud's phenomenon for 2 years, intermittent joint pain for 2 months, early morning stiffness, few minutes, no synovitis, no systemic features, no obvious cause for RP including thyroid etc. has been done. Just remember 20-year-old, what you're going to do. They come to you. Only thing you're going to do, 2 tests. One is ANA. Most of the conditions where is the connective tissue you are looking for. Only ANA if it is positive, then there is a point in looking at. Why this is important in Raynaud's? Because Raynaud's can precede so-called connective tissue like scleroderma by decade. Only presentation is blue hand coming up, white hand coming up, pain is there, sometimes you may get erosion etc. And next is what we do at our center is the nail fold capillary examinations. That will give me there is no symptoms, only Raynaud's is there. Nail fold capillary, I will show you the pictures. Here the usual things you do for Raynaud's you keep on doing. Massage is very simple. When you are suspecting connective tissue as an underlying, when this is happening after the age 25-30, elderly, if you are getting Raynaud's for the first time, be careful. Tissue diagnosis, tissue loss or distal infarct, nail fold infarct, these are important. If you are getting, there has to be a secondary cause. And most of the time, this is connective tissue disease. Negative ANA with normal nail fold almost rule out underlying connective tissue disease. Don't keep on doing scleroderma panel, etc. Don't. That's a wastage of money. Right. So everybody looks at the Raynaud's where all the fingers know. 1 finger, 2 finger is also enough. Look at the changing patterns. Another is looks a normal hand, but if carefully you look at, there is a tissue loss here. These type patients will develop connective tissue, maybe scleroderma, maybe some other, that's time will tell. Just to sensitize you, these are the normal capillary loops you are looking at. That's a nail fold. With the time, they progress in connective tissue disease. You are looking at they are getting thrombosis, looping is happening. With the time, you look, infarct start coming up. These we are seeing and putting under the nail fold capillary, that's macroscope, and examining the nail fold. This is done routinely at every center now. This is very late stage of scleroderma when giant loops are coming up and you got when you look at the hand from a distance you can say patient is having scleroderma, not having other features still. I think I will stop here and just to show you, this is my team at Medanta Gurgaon. This picture was taken before COVID. And the funny part is, if anybody has visited, Deepak is here. This is on the 5th floor. This is our urban garden. Between the 2 blocks, And on the 5th floor, we got a herbal garden for the patients. Okay, nice picture. So whenever you come to visit Medanta, visit this herbal garden. Okay, I will stop here. Thank you. Sorry for being late.
Thank you so much, sir. The chairpersons will like to ask questions.
Yes. Now audience can ask few questions from Dr. Rajiv. Rajiv has cleared all the dilemma of the rheumatoid arthritis and other connective tissue disorders. Most of us learn something and do diagnosis properly. You may ask some few questions from Dr. Rajiv.
Any questions from the audience?
No.
Any questions from the audience?
One question.
Next program.
One question from Rajiv.
So
One question
so
from the
after
Rajiv,
diagnosis,
my friend radiologist. One question from the radiotherapist.
morning.
My question is, a lot of people diagnose seronegative.
Okay.
No matter why. We have, we are at loss, what to
Right,
diagnose
so
and what to do.
first,
Look for all those tests.
so first case was so-called seronegative. Right, seronegative we call when rheumatoid factor and CCP is negative. Only these two. When you look at the cause, apart from so-called seronegative rheumatoid, which can happen in 25%, most common cause is still seronegative spondyloarthritis. One time we used to call it. Now we call is a spondyloarthritis. That's an ankylosing arthritis group. There you can have a few joints, especially in the lower limbs and the back. Then comes is a psoriatic arthritis and so many. These classifications happens, I usually call is a dumping diagnosis. Seronegative arthritis, if anybody is writing, that means that rheumatologist or clinician is not able to classify where to keep this arthritis. If pattern is bilateral symmetrical inflammatory polyarthritis involving hand and is seronegative, then this seronegative rheumatoid. Clinical picture. Just remember the first slide I have shown. Clinical picture. Blood test confuse you. Now, so what's the difference between so-called seropositive and seronegative rheumatoid? Seronegative rheumatoids we consider having a better prognosis as compared to the seropositive rheumatoid. If RFCCP is positive in rheumatoid, they will develop erosion early, they will be a little bit refractory to the treatment, and they develop extra articular manifestation early. Extra, there are so many, any organ of your system can be involved. Okay, I think I have given the answer. So anybody who has diagnosis two things, seronegative arthritis, he is a confused person, is still not able to classify. Second is seronegative rheumatoid, yes, that's a group, and it's a milder disease as compared to the seropositive rheumatoid. Yeah.
One question from my side. Paraneoplastic arthritis. Patient
Right,
getting
okay.
chemotherapy and developed arthritis. He was not having arthritis before. The small joints involved. PIP, MCP, synovitis. What to do? Where it should be branded then?
Right. So second session is on cancer. But just remember two scenario here. So Dr. Rajan Kumar asked what about the paraneoplastic arthritis? It do happens. And it's not only rheumatoid, paraneoplastic because of tumor, even autoimmune disease is much more common in all the cancer patients. They will have lot of serology coming positive. There's another peculiar symptoms coming up because of immune therapy. Cancer people are sitting. If you start doing what we do in rheumatoid, we suppress the system. In immune therapy, we activate the system. So when you are activating the system, what is going to happen? You may develop joint pain. But there, treatment is little bit tricky. The reason is cancer is always a priority. So we don't give, we give low dose of steroid for sometimes, let the immunotherapy. Immunotherapy is usually given when it's a refractory cancer you're looking at. Okay. When you're looking at the paraneoplastic, in all elderly patients, late onset rheumatoid, please diagnose it. Think about it. The most common cause, especially if it is a polymyalgic onset rheumatoid. Okay, elderly patient, first time developing at the age of 60, 65, or you look for. 3 things in the male and 2 things in the female. You must do it. Simple chest X-ray is important in the male patient along with PSA. Don't forget about it. These 2, prostate and lung. Third, don't forget about is your paraproteins. Multiple myeloma, etc. Don't forget. In the female, because of the 70-80 type of cancer will change. Still chest X-ray and thorough clinical examination has to be done. Looking for even see a breast. Dermatomyositis. Many patients we diagnosed dermatomyositis first, then coming to the, okay, you got a lump in the breast. Okay, so immunotherapy, low dose steroid, still you can give, but if you are giving more immunosuppressant, whole purpose of immunotherapy is defeated. How it works, maybe some other session we can discuss. Right? Okay, anything else?
No. Thank you.
Thank you very much.
Thank you so much, sir. Can we have a loud round of applause? Sir, regarding this patient abuse, then I will say Dr. Ravi sir, and I request for the chairperson to introduce Dr. Ravi.
I am giving introduction of Dr. Rajiv Sinha. He is product of Patna Medical College and at present Director Bone and Joint Institute in Jayaprabha Medanta Super Specialty Hospital. Completed MBS for PMCH, MS Orthopedics from Darbhanga Medical College, Bihar. He holds fellowship from Royal College of Surgeons of Edinburgh, Royal College of Surgeons of Ireland and Intercollegiate Board Edinburgh, UK. Dr. Rajiv Sinha pursued MCH Ortho from the University of Liverpool, UK. He has expertise in performing all the surgery, replacement, trauma, upper limb, lower limb in the bone and joints. He is also specialized in dealing with the complex fracture, open fractures and polytrauma. Dr. Rajiv Sinha has over 32 years of experience and has worked with several national and international hospitals of repute. After Dr. Rajiv Gupta, in spite of diagnosis and treatment, joint may damage. That was rescued by Dr. Rajiv Sinha.
Thank you, sir. Been working here at Medanta, so my welcome and greetings to all of you again. Or you can see I am so proud of my heritage as a Bihari Indian. And after living abroad for about 25 years, I never felt that I'm at my home. So my home is Patna. And I feel, even my family is not here. My wife says, "Are you happy there?" I say, "I'm happy here. I've come to my base." And I'm sorry that I have been away. And only after going abroad, I realized that how lucky I was that we had so esteemed, some of our here, so esteemed professors and teachers, that we had a good education, good training, that when I went abroad, I could feel that I'm at par with international students, and all at the cost of taxpayer money. So it's, and I felt that I haven't been able to return my debt to the taxpayer. I tried to come back here to 2012, didn't work out, but anyway, सब तभी होता है जब ऊपर वाले चाहते हैं. So, welcome again from my team at present, and we are hoping to get more consultants as our workforce is increasing. You can see that all of them are dynamic, confident, and young, of course, except me. So let's move on then. And when I came here, the people who has been seeking treatment for various conditions and not had good experience, they probably thought that this person has so many degrees and he must be qualified, he can treat all the musculoskeletal problem. And so he started coming to me with all kind of, I learned to do the operation. The rest of the thing, I didn't know much. I didn't know much about the medical side of it. In abroad, anything complex, used to go to rheumatologist. And I was trying to find a rheumatologist here. Then suddenly I thought, one person I can reach to is my friend and batchmate, Dr. Rajiv Gupta. So I said, either give me a rheumatologist or you come here. So he kindly does 2 days in a month. So all the complex problem, I hand it over to him, and the patient stays with him. So I'm very grateful to him, thankful to him. I'm lucky to have support from our emergency department. You will hear from Dr. Abhishek here. What we are providing. ICU support is immense. Radiology. I have better support than I had in UK from radiology department. Never disappointed me. Always learned something. And our physiotherapy department, with all the equipment and everything, we are a fully equipped or bone and joint institute. So let's start to what topic I was given. We all know as a doctor, our role is to try to make the life better and happier for our patient, whatever we have. Our role is mainly advisory. We are not able to force any treatment on them. Give them information, let them make the decision, inform them what is the good and bad things about it, what may happen 5 years later, what will happen 10 years later, what will happen if they are 90 or 100-year-old. So from MSK point of view, if I do something today to a 40-year-old, is that going to last when the person is alive till 90-year-old? Probably not. So what I can do now to help them so that so that we can make their life independent, dignified, able to use nature calls on their own. So that has been my objective, and most of us, of course. So let's start with the hip. I'm starting with the hip. It's not such a big problem. Say abroad, it's almost like a 50-50 hip problem and knee problem. I used to do almost 50-50 or 40-60 hip replacement, knee replacement. The hip is not that common here. But they're starting with the hip mainly because all the joint replacement, developmental science, fixation technique, materials, they started with hip problem and then subsequently applied to knee. Of course, the biomechanics is different. So we can all see this is a osteoarthritis. We don't need osteoarthritis of the right hip. So let's go into, so after all explanation, giving consent, what the patient is, their life is miserable. They can't even enjoy a single day without pain, without painkillers. So they decide to go for operation. Now the role for the surgeon is to try to give an implant. We are not as good, maybe in future happens, to give what the God has given us. So it's so whatever we do is not going to be as good what we are born with. So let's give them something that works for them, say 10, 20, 30, even 40 years if possible. So the surgeon rule is to make a pre-operative plan, and we all have a different plan. We measure leg length, clinical assessment, robotics, and computerize all sorts of things. So our aim is to get the patient walk pain-free and do most of the activities. They probably won't be able to do yoga where you can bring the leg behind the neck, but at least they can live and use the bathroom and toilets without significant pain. So this is the pre-operative planning that I have been used to provide the service. Now this is the outcome. I'm sure most of you have seen this X-ray. There is a little debate. I try not to go into the literature of cemented and uncemented. But this is, which is quite important, this is the uncemented implant. Now, uncemented implant they have got a different layers, good coating, micropores. So the idea is that the bone grows into the metal. So therefore, it becomes part of the body. We all know when we are 40-year-old, bone is not going to be strong when we are 70-year-old. So the question is it going to get loose, or is it going to stay as it is, going to be painful? So uncemented implant gives us an option of making this part of the body and so that hopefully it doesn't go. Now this type of implant has been used all over the world for about 25-30 years, and the result is fantastic. It's still 75 to 80% of them is still working, is still in place. So there is a modern technology of using uncemented implant. Unless someone is really 70-80-year-old, then the quality of bone may not be good. Coming back to what problem that people have we can address to and how we can make their life better, if not back to normal. So this person, we haven't got the full spine X-ray, but he has got a significant leg length difference, probably about 3 to 4 centimeters, all mainly because not only hip osteoarthritis, because of the spine above that. And the spine surgeon wouldn't touch it because they have no, we don't have that expertise to someone who is multi-level degeneration to bring the back normal, to bring the pelvic steel back again. So, and the patient is in pain. So we try to aim to get what is the leg length difference and how we can bring it back to normal, even if not back to normal, bring it so that they have a slight heel raise and able to walk without limp. Simple X-ray is still our first investigation, and standing limb length X-ray tell us how much limb length we can make a difference, and then the person had the cemented hip replacement at that time because probably 75-year-old, and is still a bit short on the right leg, but with the slight heel raise, able to walk and able to go back to normal activity. So coming back to after leg length dislocation, our hip are very stable structure. Unless we fell down from second floor or had a motor accident, the hip doesn't usually dislocate. But our hip, which is the man-made one, is not so stable, and it is a well-known complication, hip dislocation too. Now there are new technology like dual mobility hip and everything, but someone who had the previous hip replacement, they keep on dislocating even by sitting on the chair. There are options available, a simple procedure called Platt technique that keeps the hip in place. So there are simple solutions that we can use, someone who is having problem. Now we have all heard of Percy disease and development dysplasia of the hip. These people were young when they had the problem. By the time they are 30, 40-year-old, they have got the arthritis, a bad arthritis, short leg, limping. They are the workforce, they're supporting the family, and not able to do the job. So this one, someone has a Percy disease and quite arthritic hips. So if you give them cemented hip, they're not going to last very long. So uncemented implant is an option for them, so that they can do their normal activity with some restriction. Of course, they won't sit below the chair, but office activity, riding motorbike or driving is not a problem. Again, the other one is this complex hip with the coxa magna. Again, the uncemented implant, bring them back to normal life activity. I wouldn't go into that one. Protrusio. Now, if you ask me what is the indication for joint replacement, it is pain, pain, and pain. With the last pain, we can add limitation of movement, deformity, where we have to intervene early. So this person didn't have much pain, mainly because there is no joint left. There is no movement happening at the joint level. He's not in pain. The question is, what do we do? How is he going to get it? He can't even sit on the Western commode because he has to keep the leg straight. So there is no other option to give them a joint replacement surgery, which will give them mobility. So that's what we check for all the joints and then had the joint replacement. So all these, sometimes we have to intervene mainly because joint is getting deformed or have the loss of function. Coming back to the old implants, 10, 15-year-old implants could break as well in the middle without simple fall, just by the fatigue. So there are options to give them a better implant next time so that it doesn't happen again. I'll just go into trying to cut short. Now, when this one came, this is popularized all over the world. It's a hip replacement. It's a surface replacement. You can see that most of the neck is still there. And it's popular as a Birmingham hip. When this implant came in, I was so happy. Most of the Indian surgeons were so happy. Now we can offer an implant where people, after hip replacement, they can use Indian commode because it's the same size as our normal hip. And we all quickly learned this technique so that we can go back to our country and start practicing that. Unfortunately, after 5-10 years of this implant, they start having problem. It's almost the same, like you see that the metal rubbing over the metal and generate debris, and they start failing. So we still, well, I would say watch this space. There may be more better ceramic implants coming, which we can provide in future. I just covered that the hip because of the technology advancement. Most of the material structure development is started now coming to knee replacement, which is a major problem. I think it's an epidemic. If the lady comes to me over 40 years of age and doesn't complain of knee pain, I'm surprised because it's so common. And so I ask them, are you sure you don't have any knee pain? As they say, okay, fine. But it's a very common problem. Now, we probably have seen, before coming back to that one, we all have seen probably this kind of x-ray and knee replacement x-ray. Whoever in medical faculty probably have seen those. So I would just थोड़ा side इधर आ जाइए देखने में दिक्कत थोड़ी. We all have seen that one. I'm just bringing up what option do we have. do we have just one medicine for everyone who has the knee osteoarthritis, knee arthritis? The answer is no. And because it depends on what stage of life they are in, what age they are in, what can we give them that hopefully they will have pain-free, dignified life when they are 90 or 100 years old of age. So someone who is, let's accept it, the joint replacement that we have, especially knee, may last about 20 years. If someone is over heavy and something, probably 18 years, maybe 20, 25 years. So if there's someone is 40, 50, 55, they are going to need a second operation if they live long enough. And see what we can do. The problem with the second operation is not very big, because second operation, where there is a bone loss, it's a major issue. Almost complication goes 10 times more. So just to compare that with the next slide that I'm presenting, which is a unicondylar knee replacement or half knee replacement. So, and there are other options that we can do for the patient. So just showing the picture what I'm going to bring the attention to. So for any procedure, we have to clinically diagnose, does it match up with their symptom, or just looking at the x-ray, see the arthritis, or you need a new knee. It's not like that, because that person may not have any pain. I mean, look at the farmers in England, they are 70-year-old, they have got their knee x-ray, looks like horrible. How they're managing, but they say, oh, I still can ride tractors, I still can walk, I can ride the motorbike. They don't need any operation, their life they carry on. So there are people here as well, they don't need the operation just because the x-ray shows arthritis, if they are able to manage most things. Of course, I do look at them, and if they're developing a deformity like this or something, then even if they are not in pain, I recommend them to have the joint replacement done, because otherwise it will start getting problem in the future, and it gets more complicated, and they may require a special type of implant, which is not ideal. So all the options, so the knee replacement for an knee joint for an orthopedic surgeon is basically 3 joints, which is medial, lateral, and patellofemoral, depending on what symptoms do they have. So if someone just having a pain that on the inner aspect of the knee, I look at the x-ray, very straightforward, just arthritis on the medial joint, they may be happy with the medial unicondyle knee replacement. If someone complains, I get the pain when I sit on the floor and get up or go on the stairs, they probably also have patellofemoral. So you have to match up with the x-ray with the symptom. Does the x-ray match up with the symptom? And so I get the different x-rays at, so my standard is, I had to convince people that when I started here, any knee x-ray, first question is this standing x-ray? 90% of the time outside was not standing. It's not good. It's just rubbish. So I had to request them, look, if you don't mind, I'll get a standing x-ray. So I get the standing x-ray. And my standard is, in a young 70-year-old AP and lateral knee x-ray, that will do. 30, 40, 50-year-old, I will also get the skyline view. I'll show the x-ray in a minute. Now, if they don't have any mechanical symptoms like चलते हैं तो पैर कचक जाता है या सीढ़ी चढ़ने उतरने में मुझे पकड़ना पड़ता है, then there can be soft tissue or meniscal, then only I get the MRI scan to look into it. Otherwise, MRI scan is not my first line of investigation. Unfortunately, a lot of people come here, they had the MRI scan, when I say I need the x-ray, they look at me and say, dog, I had the MRI, why you need an x-ray? But this is what we have to convince people. Now, going back to, I had to teach our x-ray department what x-ray I'm going to need. So this is my x-ray, my picture, showing them what x-ray I'm going to need. And there is no exception. You have to learn this. If you have to work with me, you have to learn this. I'm not going to change my practice. So this is, this. Now, if you look at these 2 x-rays on the left, they were just standing x-ray. And we still see the joints are preserved, but the patient has a lot of medial symptoms. So my question is, where is the pain coming from? Is it the medial joint? It looks intact. Sometimes you get the pain from the, sometimes you get the pain, referred pain from the hip as well. So I in a way, my practice is to get the hip x-ray. Very occasionally, referred pain from the spine can be a bit of differential diagnosis. So did the x-ray with the standing like this, and you can see what it looks like on the left. It's showing up quite advanced medial joint arthritis. So the diagnosis is pretty clear that he is getting the pain in the medial joint. The question is, can he carry on like this? Does he want to live with simple painkiller exercises, or is it bad enough that he wants a knee replacement surgery? So that's what, this is not the, so not simultaneously done, but this is the unicompartmental medial joint replacement, and that preserves most of the ligament. They can do whatever they like, even they can do yoga. I would not recommend to go for a run, but other activity, walking, cycling, they can do all of those. And the recovery is quite quick as well. So this is something not very well known, except probably places, Delhi, Mumbai, etc. I wouldn't be long here. Now, coming back to another one. Oh, they probably haven't uploaded that view. I'm sorry, it's one X-ray I just uploaded last time is not there. Let me just check 1 second, it's not there. Oh, okay. So it's, so my apology, the one X-ray that I uploaded, what was in that X-ray, that all the joints are well preserved, but the patellofemoral joint was very arthritic, and the person is not able to do most activity so there is an option of just replacing the kneecap as well. And if this lasts for about 15 years, by the time they're 60, 65 or 70, the second procedure, which will be a knee replacement surgery, will be very simple. All you can do is to take away the implant, and already the patella is done, and it's like a first operation that will last 20 years or more. So hopefully that will sort out the rest of the life problem for that knee. So we can. So that's what I'm saying is we have to just tailor-made treatment for what knee problem they have. And if the replacement, they can have patellofemoral, medial, lateral, or total knee, depending on their need, depending on the things that how old they are, what their activity needs are. Let's go to, there are options for someone with deformities, not only here, even in Corona period in UK, people didn't get the operation and their knee were like this when they're coming for operation. So there are options for that one, a little bit more complex. A hinge knee where the ligament is damaged is a little bit more complex surgery, it takes longer recovery. Results probably not as good as primary. So that's why I say, if you're getting the knee deformity, don't wait long, and if you are struggling with it, get the joint replacement done. So just a few, and I'm very grateful that we had, you can see that we are providing a full support. This lady with her consent had a knee replacement done. Our physio are visiting at home, getting a joint replacement, getting it moving. I tell them you got to get the movement within 4 to 6 weeks, not going to get. So they probably see me the first consultation as a kind doctor, but when they see me after the operation, they're probably the most unkind person I become. I don't care about how much they pay in there. They give them painkiller, I make them work hard. I get them promise that 4 to 6 weeks, you have to work hard. Otherwise, if you're not going to listen to me, don't come to me. I have to have my standard. You have to come to my standard. I'm not going to come to change my standard. So this is, the same person had the mobility. The 4 to 6 weeks they struggle. Everybody struggles, and after that they get rid of the walker frame. They do most activity, and I find the recovery is quite good. We are also not only joint replacement. We're also working on the complex trauma as well. Just to add that we are providing the full package at present in our hospital, and it is expanding. It is just over 1 year the department started, so we are expanding on it, and hopefully we will have all the other separate consultant for sports, for tumor, hopefully soon. So thank you very much for your time. I'm grateful. Just say one thing. About the treatment, and that I didn't know, whoever, I don't know, still the first and second year we read physiology and trauma, and I thought, have I come at the right place? Is it what I want to do? Accidentally, probably, Angel guided me to go into trauma theater. Accidentally went to, I saw the people are using Cheney and Hattori. I said, oh God, this is what I want to do the rest of my life. I never thought about I can do anything else. So here I am. I can't think of anything other than orthopedics. Thank you very much.
The chairperson, any insights from the chairpersons?
Thank you, Dr. Rajiv, for good presentations. Audience can ask questions.
Any questions related to Cheney, Hattori, orthopedics? Just any questions from the audience?
No orthopedician is here.
No questions? Thank you so much.
Thank you.
It was just in jest. Come, please. What is?
Quickly request to you, what are you doing? What are you guys doing at Patna?
The question which Dr. Ajay had, कि आप लोग क्या कर रहे हैं पटना में?
मैं आंसर कर देता हूँ.
Dr. Rajiv, what you are doing, which is complication developed by the tuberculous hip. TB is healed and patient wants THR. What we will do?
Well, of course, we have to assess the whole patient and what condition they are in, how old it is, how long ago.
After how many months we will do THR in tuberculosis?
And I must say that I've done after pyogenic, not done after TB because this was not that common in UK. After pyogenic, bone quality, bone stock, what is their movement, what is the problem they are facing, are they able to do most activity, is it just the joint, can they manage the bathroom, toilet and everything? First thing I would say, if you are able to manage without pain, live a dignified life, enjoy life with the family, better not to do anything. Because there is no guarantee that you will definitely improve. Is there a question of, are you getting, you may end up worse? Of course there is. There is a possibility that it can end up worse. So first is assess and try to symptomatic relief and avoid any surgical procedure whenever there is any place of infection. And if the bone quality, do all CT scan, everything, what the bone quality is, are you taking the bone stock, am I going to do uncemented, I'm going to do this cemented, what is the leg length difference? It is, the implant will be the same if they decide, I have to explain to them, there is a possibility of recurrence of either pyogenic or tuberculous, come back to them, and there is a possibility that the operation may fail, that the option will leave them to have a girdle stone where we excise the hip, so they can end up with girdle stone arthroplasty, which takes away the pain and leaves the leg about 2 inches short. They have to use the rest of the life with the heel raise. So if they are prepared for that, then I would and want to go for operation, I would offer them.
How many cases you have done so far?
No, not after tuberculosis, but after
In general.
the hip replacement.
Yeah, hip and knee.
Oh God, I lost count. I counted after 10, 15 when I was starting as a registrar, but after that, well, when you're UK, you can't do hundreds in a week or a month. The Patna, the knee replacement is quite commonly done. So numbers are not very high because it lasts, first 6 months, it has to convince people that we can provide you service. So the numbers have gone quite up.
Thank you so much, sir. Thank you so much. Can we have the next speaker, Dr. Abhishek?
So now I welcome Dr. Abhishek.
Yes.
Abhishek Kumar is a consultant emergency and trauma care in Jayaprabha Medanta Super Specialty Hospital. He completed his MBBS and MS surgery from Patna Medical College. He pursued MCS trauma and surgery and critical care from AIMS, New Delhi. Abhishek Kumar specializes in treating trauma victims, which include exploratory laparotomy, thoracotomy, traumatic vascular injuries, maxillofacial injuries, extensive soft tissue injuries, and minimal invasive surgery. He is trained in treating patients in disaster and mass casualty. So today he is going to talk about on the damage control resuscitations. That means how to limit the loss of the blood, how to do the hypotensive resuscitations, and prevent the coagulopathy and resuscitation with the blood and the blood products.
Yes.
So proceed.
Thank you, sir. Good morning, everyone. Before starting the topic, let's start with a case scenario. A 47 years old male, alleged history of firearm injury to his left side of the chest. He presented to our emergency after 4.5 hours. On arrival, his airway was patent. He was tachypneic. His saturation was 88 on room air. Breath sounds was decreased on the left side. Chest compression test was positive on the left side. He was tachycardic, hypotensive. On Foley's catheterization, there was a gross hematuria. We did some investigation, E-fast done, which was positive. Chest X-ray was almost normal. There was no hemopneumothorax. Pelvic X-ray was normal, but there was a foreign body inside the abdomen. Looks in the abdomen. Initial ABG showed lactate level of around 7. So we resuscitated the patient with a crystalloid and patient responded to the crystalloid. But after some time, there was a sudden drop in his hemodynamic condition. So we intubated the patient and rushed to the OR immediately. This was the clinical picture. There was an entry wound over his left side of the chest. X-ray was looking unremarkable. On pelvic X-ray bones was normal, but bullet was at the L3 level. So on the OT table, he was on high dose of inotropes. Midline laparotomy was done. Intraoperative findings was gross hemoperitoneum around 1.5 liter. There was a rent in the left side of the diaphragm. There was a subcapsular splenic hematoma, double perforation in the transverse colon near the splenic fracture. There was left perinephric retroperitoneal hematoma. So with these vitals and intraoperative findings, damage control intent was made, and we secured the hemostasis, packed the abdomen, stapled the perforated colon, ICD was inserted, and blood products were transfused. Total duration of the OT was only 45 minutes. After OT, patient was shifted to the ICU for resuscitation. After 14 hours of ICU care, patient became hemodynamically stable. So we took the patient for full radiological investigation like CT torso. This was the CT images. We showed the pack inside the abdomen. There was a foreign body in the left chest and bullet in the back at the subcutaneous level. There was grade 3 left renal injury with perinephric hematoma. So after patient became stable, after 20 hours of first operation, we took the patient again to OR for definitive anatomical repair. We did diaphragmatic closure, colon was repaired and transverse colostomy was made, and abdomen was closed in layer. So we discharged the patient after 8 days of hospital stay. So we managed this case in a staged fashion. First we do a damage control surgery. After that we resuscitated the patient in ICU. Again we took the patient to the OR for definitive operation. So the concept of damage control comes from the United States Navy, which represents the capacity of a ship to absorb damage and maintain mission integrity. Means we have to make the patient alive throughout our journey. Initially in 1983, Stone was the first surgeon who did the truncated laparotomy. But after 10 years, Rotundo coined the term damage control surgery as a 3-phase technique. So damage control surgery is a concept of abbreviated laparotomy designed to prioritize the short-term physiological recovery over the anatomical repair in a seriously bleeding, injured or compromised patient. And the similar term damage control resuscitation, it is a systematic approach to a major trauma patient combining the ABC of paradigm with a series of clinical techniques from point of wounding to the definitive treatment in order to minimize the blood loss, maximize tissue oxygenation and optimize the outcome of the patient. So what is the main culprit in a major bleeding trauma patient? In a trauma patient, there is a hemorrhage, and this hemorrhage will lead to the hemorrhagic shock. This hemorrhagic shock will cause acidosis and hypothermia. These both will cause coagulopathy, and coagulopathy adds again to the hemorrhage. So this is a lethal triad in a trauma patient. If we keep on resuscitating the patient with the fluid, then it will add on the dilutional coagulopathy and adds on hypothermia. If we expose the patient more for the operative time, then also adds to the hypothermia. So there is a lethal triad of trauma. So our purpose or the concept of damage control resuscitation to break any point of this lethal triad. So initial surgical teaching was when a major bleeding trauma patient come to ER, he will go to the OT and result was not very good. So standard teaching was in a major trauma patient, first do a damage control, then resuscitate the patient to the ICU, again do the definitive repair, and then again resuscitate the patient to the ICU. So the damage control surgery has a 4 phase. Phase 0 is a ground zero phase, which means when patient received to our emergency room. This is the phase of initial resuscitation and evaluation. We have to follow the ABC of the patient, airway, breathing, circulation, and we have to follow the ATLS guideline, and we have to manage the patient. We should not take more than 20-30 minutes to complete diagnose the patient. Next phase is abbreviated laparotomy. That is damage control surgery. It might be damage control laparotomy, thoracotomy, damage control orthopedics, vascular surgery, or it may be damage control craniectomy of the brain. The basic principle of any damage control surgery is to control hemorrhage, to prevent contamination, and to avoid any further injury. And the main aim to restore the physiology at the expense of anatomical reconstruction. Ongoing resuscitation must be there throughout the operation, and this phase should not take more than 90 minutes. The next phase after the damage control surgery is resuscitation, and it may require 12 hours, may up to 24 to 36 hours. And the main goal of this damage control resuscitation is to reverse the sequelae of hypertension related metabolic failure. That is physiological or biochemical restoration, adequate oxygen delivery to the body tissue, aggressive core rewarming, aggressive approach to correction of the coagulopathy, and we should do tertiary survey at this point. So there are these are the tenets of the damage control resuscitation. When any major trauma patient coming to the ER, we should rapidly diagnose the case, whether it is whether bleeding is taking place or not. So we have to do focused clinical examination and focused investigation. After the rapid diagnosis, we have to limit the crystalloid. Initial 1 liter of crystalloid is allowed. If there is hypotension or patient is bleeding, then we have to initiate massive transfusion protocol. That is 1:1:1 transfusion strategy. Initial antifibrinolytic has role if we initiated within 3 hours of any trauma. And we should have permissive hypotension. The MAP should be around 90, because if there is a hypertension, there may be chances of clot dislodgement and patient may bleed again. And the last damage control surgery, which is a part of damage control resuscitation. And the next phase is the definitive surgery. The time is very critical for the definitive surgery. With a focused management and the resuscitation, we may get a full physiological recovery after 24 to 36 hours. In this phase, we have to look for any hidden injury. We have to check for any missed injury, which we have done in the damage control. And finally, we have to address all the definitive repair is this phase. This is the damage control surgery timeline. The phase 0 should take maximum 20 to 30 minutes. When patient come to the ER, we have to rapidly diagnose the case, do some basic investigation. After, if that case is for damage control, then we took the patient to the OR. The first operation, that is which is damage control, should not take more than 90 minutes. After operation, we have to send the patient to the ICU for resuscitation. And after resuscitated patient, we have to took the patient again for definitive repair. So we have to know what are the indications in what type of patient we have to do damage control. So the foremost indications is severe degree of physiological insult. Like if we found hypothermia during pre-operative or intraoperative, so we have to think of damage control. If we find clinical or laboratory evidence of coagulopathy during intraoperative period, then we have to think of damage control. If there is evidence of persistent cellular shock, means if the pH of the patient is less than 7.2 base deficit is more than 15, or if there is a evidence of lactate more than 5, then we should think of damage control surgery. If we have inability to control the bleeding using the conventional method, then we have to pack the cavity. If large volume of blood and blood products required during the initial resuscitation, then we have to think of damage control. And if we found injury pattern identified during the surgery that is difficult to access the major venous injury like intrahepatic, retrohepatic, retroperitoneal or pelvic. If there is a major liver or combined pancreaticoduodenal injury with hemodynamic instability, so we have to think of damage control. If there is combined pancreaticoduodenal injury with massive hemorrhage from the head of the pancreas, then we have to think of damage control. If there is devascularization and massive disruption of the duodenum, pancreas, pancreaticoduodenal complex, then we have to do damage control. Now, last but not the least indications, if we have inability to close the abdomen or thoracic wall without tension because of the visceral edema, if there is a sign of any intra-abdominal compartment syndrome, then we have to leave the abdomen open. If there is a need to reassess the abdomen to know the extent of bowel viability after a period of further resuscitation, then we have to do damage control surgery. So after damage control, there are some complications of that. That is, this is the austere environment during the surgery, so we can miss some injuries. We have to, in some time, we have to keep the abdomen open. There are chances of enteroatmospheric fistula, and there are possibility of abdominal compartment syndrome also. But with the intent of damage control resuscitation, many patients can survive. So the take-home message is, management of exsanguination requires prompt action and aggressive surgical intervention. Delays in the decision to perform damage control contribute to a higher morbidity and mortality. Damage control surgery is a vital part in the management of severe injured patient and should be performed before the metabolic exhaustion. Thank you. Any questions?
So, any questions from audience?
Any questions from the audience? Let's move on. Thank you. Thank you,
So,
Dr.
thank you, Abhishek.
I just
Thank
want to
you.
make a comment.
Yes.
This gentleman, young man, who is very well known to us in our hospital. He's a bullet surgeon. I call him bullet surgeon because all the bullet injuries he has been doing. A lot of people, difficult patients from Champaran, where gunshot injuries are all so common. You know, he has handled beautifully. Thank you.
Abhishek, what
sir.
about bullet when hit the bone? Bullet hit the bone,
Yes, sir.
then DCS.
If there is a fracture and if there is a component of soft tissue, then we have to do the DCS.
And rest part treated by the orthopedic surgeons.
No. In that part, we have to do the external fixation and we have to manage the soft tissue first.
Okay.
That can be done by the trauma surgeon also.
Thank you. Thank you.
So for that we used a Chenia Nathora by Dr. Rajiv Sinha. Okay, thank you. Okay, let's move. So I hope you take it in jest. Just don't get annoyed. Don't get annoyed. Don't get annoyed, please. We'll meet over a cup of coffee. The coffee is from me. Okay. I have amongst me in our midst we have Dr. Ajay. Dr. Ajay is a prominent practicing diabetologist in the state of Bihar. Firstly, can I welcome him with a big round of applause? And I'd request him to kindly felicitate, firstly, starting with the chairpersons. Sir, can I have you on stage? The ladies over here, please come up. Okay, let's start with Dr. Manish. Sorry, sir. It's okay. It's okay. Dr. Rajan Kumar, please. In the middle, yes. It's okay. Be comfortable. We have a lunch for you as well, so kindly use the energy next lunch mein. Okay.
Rajan was my student, incidentally.
Dr. Manish. Dr. Bharat Singh. Can I have the speaker, Dr. Rajiv Gupta? Sir, are you there? Dr. Rajiv Gupta? Okay, sir, please. Can we have a round of applause, please? Come on, it's becoming, I mean... Hurry up, please, hurry up. Next, Dr. Yeah, this is Dr. Yes, please. Two Rajiv, so that's the confusion actually. Next, Dr. Rajiv Sinha, sir. The trauma expert, Dr. Abhishek Kumar. Dr. Abhishek. Yeah, please. Okay. Moving on to a second session. Can I have on stage Dr. Shanti Roy, a name synonymous with OBS and Gynae care in the state of Bihar, a doyen of OBS and Gynae in the state, also an ex-HOD, Patna Medical College and Hospital, another doyen of OBS and Gynae in the state of Bihar, Dr. Shushma Pandey, ma'am. Please, can someone just escort ma'am on the stage, please. Dr. Shipra Roy, ma'am, can we have you on stage? Escort, please. You just escort, please. Dr. Ridu Kumar Sharma, medical oncologist, Magad Cancer Center. Okay. I'll personally take the pleasure of introducing the ever-smiling, dynamic, beautiful Dr. Sarita Sharma. Allow me to say a few words regarding Dr. Sarita Sharma, a senior consultant in the Department of Gynae Onco and Minimal Invasive Gynecology at Jayaprabha Medanta Super Specialty Hospital, Patna. Ma'am has completed her MBBS from Nalanda Medical College and Hospital, followed by DGO from... We've got a power cut. Do we have a backup? Am I audible? Am I audible? I believe should. Okay, let's continue. Let's continue. We'll have to deal with it. Okay. In 2012, she completed her DNB in quickly, shortly. 2019-21, she completed her training in robotic and gynae oncosurgery from Jewish General Hospital, Montreal, Canada. In 2020-21, at Lady Davis Institute at Jewish General Hospital, Montreal, she was a part of Translational Research Project, and she's been trained in diagnosing and treating gynecology gynecological cancer of ovarian, fallopian tubes, uterus, cervix, you name it, and she's an expert. Before ma'am actually takes over the stage, can we have you over here, ma'am? Anyone from the audience, why is she specifically wearing a pink sari? Would anyone like to answer this? Dr. Suraj, would you like to give a guess why is she wearing a pink sari? No, your smile is great, but can you just give a guess? Abhishek, any reason for wearing a pink sari today? Anyone, why she chosen to wear a pink sari? No answers? Yeah, please. Any reason for wearing a pink sari today? Pink? Okay. Sure. Yeah, please.
Sorry to interrupt you, and thank you for your kind words. Being a woman, I am dealing with a female cancer. So I want all the women to be in the pink of health, both in health and shape. Thank you. And the second thing is, before he can adjust everything and assemble, my father bought this sari for my mom 25 years back. She did not wear it even once. उसका कहना था मैं ऐसे साड़ी नहीं पहनती. So now after 25 years, I am wearing this sari for the first time. Thank you. So now I don't want to waste time because the buzzer boy is always knocking on our head. So, I'm 2 months old over here at Medanta Jayaprabha. Before coming to this place, I was at Medanta Gurugram. Now, this conclave was announced while I was just 2 weeks old over this place at Jayaprabha. So then in the first 2 weeks, there was one ovarian case in which the frozen section was serous, adenocarcinoma, and then I have to do pelvic lymph node and total lymphadenectomy. And then the second case was a large dermoid cyst, 18-20 centimeter. I did laparoscopy. So then I thought this is the best case I can discuss in the conclave. But then you will be surprised to notice the kind of... But my decision regarding which case I should be dealing changed after I saw these 4 cases in just a span of 2 weeks, and all these 4 cases are locally advanced case of CA cervix. So then I thought, look, since 2018, the world is advertising that we plan to attain, public, to eliminate cervical cancer as a public health problem by 2030. So are we anywhere in achieving this in just span of 2 weeks? I think the pointer is not working. Okay, anyways, Asuta, the pointer is not working, please. So then I just want to ask everyone, are we anywhere near to achieve the target of attaining cervical cancer elimination by 2030? I don't think so. So then there is a big no. So, in 2018, this idea was proposed. But after we traversed 2 years down the line, in 2020, the WHO proposed that, look, with the pace we are running now, we won't be even able to achieve this target by 2030. It was proposed that with this speed, we'll be able to achieve only something between 2085 and 2090. But with the current scenario, what I experienced, having 4 cases of locally advanced CA cervix in just span of 2 months, I don't think even we are gonna nearby to achieve that by 2085 to 2090. So now, what are the steps as proposed by WHO, by doing which we'll be able to attain by 2085? So they have brought an idea that we at least vaccinate 90%, completely vaccinate. So now this is completely vaccinate, not just a single dose, but completely vaccinate 90% of the women, like young girls, by 15 years of age. I don't think we are there. Coming to the second step, like screening, so it's proposed that we screen at least 70% of the women of the reproductive age group, and at least by 2 screening tests. And the most, quantitatively best test as proposed by WHO is HPV DNA test. Now, twice screening is once at 35 years of age, and the second is by 45 years of age. Those who are diagnosed with any kind of cervical disease, even cervical infection, we are supposed to treat 90%. After we are treating at least 90%, then only we are going to achieve this. I don't think we are anywhere near to that. Now, after this, it is very surprising for me. Like in Medanta, 50 to 60 pap smear was done in a day, and that was, chosen by the patient because there was executive health checkups, so they opted for it on their own. Now here, I have to counsel them, and in one day, I hardly get 2 or 3 pap smears in a day. Now, coming to this scenario of the lady who has, incited me to choose this as a topic, is that she is a 52-year lady, postmenopausal since many years, and then in the last span of 2 years, she has 2 or 3, even more than, I think, before 2 months, she has even 4 or 5 episodes of postmenopausal bleeding. She never had a single screening test done in her life. All those 4 patients, they never were screened even once by any kind of screening protocols. Now, the examination which is pertinent to this patient is like there was no inguinal lymphadenopathy, no supraclavicular lymph nodes enlarged. And then when I tried to do a per speculum examination, there was difficulty in positioning, being a 52, and then as soon as I entered, I realized that there is a vaginal mass which started to bleed, and then it was difficult for me to continue the examination further. So then I decided to do an EUA and take the sufficient biopsies, but before doing the biopsies, I sent her for an MRI examination. So then I'll request our radiologist, please, to comment upon the MRI finding of the patient. Yeah, please.
Good morning, everyone. You all know that MRI is the best modality of choice for local staging of CS cervix. So I'm here to describe the findings. You can see there is large mass involving the cervix, extending to the lower uterine segment and involving the upper vagina. And on axial image, you can see there is enlarged left iliac lymph nodes. So it's involving the vagina, and there is a lymph node. So radiologically, the stage is 3C1 because involving upper vagina and there is lymph node. If the lymph node is pelvic only, then it is 3C1. If the lymph nodes are retroperitoneal like para-aortic, then the stage would be 3C2. So all these things from my side. Now over to Dr. Sarita.
Thank you, Dr. Rajiv. So then, I did take her for examination under anesthesia and took biopsy. So you can notice it, the pink area, there is a cervical mass which was seen protruding through the external os, the mass extending to the right fornix and then going down to the vagina. There was no mass, at least in the distal 3 centimeter from the introitus, and the extent of the vaginal mass was 3 centimeter in length and 2.5 centimeter transversely, but the major area or the major extent of the mass was in cervix. Now I took biopsy from the vagina, from the area, the cervix, and then I did dilatation and drained the pyometra. So then after a couple of days, we got the histopathology report, and then I'll request our pathologist to have his comment, please.
Thank you, Dr. Sarita. So we received the tissue, as Dr. Sarita mentioned. This shows keratinizing squamous cell carcinoma, and we know that the cancer cervix squamous cell carcinoma is either non-keratinizing or keratinizing. Majority are non-keratinizing, and they are all HPV associated. Usually the keratinizing are one or those, they are not HPV associated, and they don't carry a good prognosis as the non-keratinizing one. So this is all from my side.
Thank you, sir. Thank you very much. Now, thereafter, with the impression of the pathology and the imaging finding, we did radiological imaging, and then we did take decision regarding treatment from our radiation oncologist, because she is already stage 3 C1, or because this is the recent from 2018 that we take help of the imaging for the staging. So I'll request Dr. Rajiva, our radiation oncologist, to have his comment on this.
Good morning. Locally advanced CS cervix patients are always treated by radiation, and you use chemotherapy to enhance the effect of radiation, and they need both external beam radiotherapy as well as the brachytherapy. And the thing that I would like to mention here is that now things have changed. Now everything is image based, and there has been a huge change from what we used to practice and what we are practicing now. Thank you.
Thank you, sir. Thank you very much. Now, this is the take-home message. Why I introduce this case to the audience, that look, it's not we who fail. It's the patient who are not opting for any kind of screening test. So to solve a problem, the patient has to take few steps, and we also have to take few steps. It's not that any of the screening test has come out to be a false negative. They did not go any kind of testing. Now, since as per the WHO, the world is in a transition phase. We cannot just recommend that HPV DNA is the ideal test to screen all the women, because this is not acceptable, accessible, and the resource in many countries are very limited. So we cannot put just HPV DNA as a test of choice for screening. But then, this happened twice to me now. So then, what we are supposed to do is at least continue doing whatever screening you are doing till HPV DNA is available to all the countries, even so resource limited places. Now, even if we are doing cytology, you continue doing that with the protocol that annually one pap smear, if all three are negative, you are free and reassured for 3 years. But at least what I am doing right now, that I am taking opportunity to counsel all the patient whosoever comes to my clinic, like even if they have some other complaints like excessive discharge or dysfunctional uterine bleeding, but I definitely invest 1 or 2 minutes of my time with that patient to counsel her for screening. Second, there is an executive health checkup and the adolescent clinic. Why I am putting importance to this adolescent clinic? Because, you know, I stay in Kankerbagh and that's a good society. But I feel like there are already 10 girls aged nearby around 15, but I am sure that none of them are vaccinated with HPV. So if this is the current situation for vaccination, I don't think we are anywhere closer to attaining this goal even by 2085 or 2090. Now, patient thinks that HPV is costly, but just imagine annual pap smear cost here it is costing 600 for one test. So 3 years it will be 1800. One pap smear is 1 HPV DNA is 15 years. If HPV DNA is negative, she is free for almost 5 to 10 years. So which is cheaper? HPV DNA is cheaper than doing pap smear annually for 3 years, and then after all these 3 are negative, you are again supposed to do it after 3 years. So it's a better decision if HPV DNA is easily accessible, acceptable to the patient. We should promote HPV DNA in all our setup. Oh, so thank you everyone, and I think I am on time.
Thank you very much, Dr. Sarika, for the nice presentation. And as you know, the carcinoma cervix is the cancer which is most preventable because it is slow growing, and cytological evaluation is very common, because if we are doing the pap smear of every woman who are coming to our clinic, especially lady doctor and gynecologist, for any problem, then we can detect it early. And the treatment is very good, there is no doubt in it. And HPV virus etiology is known. That is also, so the prevention is better, always better than cure. And it is the awareness regarding the vaccination in the school girl going, in the schools, and every woman, especially in the postpartum period, when we are giving the advice for the family planning. And we should also write that the HPV vaccine should be taken to prevent the carcinoma cervix. And screening, second thing is the screening. So very much, very good presentation, Dr. Sarika. Congratulations.
Thank you very much, ma'am. Thank you for the nice words.
Dr. Sarita, your presentation was superb.
Thank you,
I
ma'am.
liked it very, very much. It was very clear, very informative, and very nice.
Thank
you
very
so much.
Thank you, ma'am, for coming and blessing us. Thank you.
Yes, very nice multidisciplinary presentation. So we
Thank
had
you.
input from all sources. I'd just like to give an anecdote. My mother has been holding health camps in our ancestral village, which is in a almost deprived area at UP border. And it's been ma's burning desire to do pelvic examination for all women to detect cancer early, even if they can't get a pap smear, at least to have a visual assessment. And in spite of having a doctor of mass stature and other teams from Chapra, Sivan, gynecologists presence, the local women refuse to have the examination done.
Exactly.
So you can, take the water to the horse, but you can't make it drink. So that's the level of ignorance that in spite of all that effort, women are still not understanding the importance of screening and getting, treatment done in time. Women who come to us are a selected population, so we do routine screening for all non-pregnant patients, and but these are selected because they've already opted to have health care, so there is some self-screening involved, but it's the majority of the population which doesn't understand the benefit. That's where it needs to go, and unless government includes HPV vaccine in the vaccination program for children, it's not going to happen. Because we have people still refusing to get the neonatal girl screened for jaundice and thyroid. They are not going to bother about cervical cancer that's going to happen 30 years later. So unfortunately, that's the mentality still in our state.
Yeah, very true, very true.
I have a few comments. For prevention of cervical cancer, vaccine is very important. But if you see the incidence rate between few states and countries like in India, Kerala and nearby Tamil Nadu, incidence of carcinoma cervix is very high in Tamil Nadu as compared to the Kerala. And for prevention, we need to focus on menstrual hygiene and pelvic hygiene. Another thing is this is a socioeconomic disease.
Yes.
In higher socioeconomic strata, cervical cancer is coming down and breast cancer is increasing. One of the things. Second, what about the FIGO staging? Clinical staging?
She was stage 3C, C1, because there is involvement of the pelvic lymph nodes on imaging.
Clinically, you can't detect the node. I think in diagram you have shown that there is para-involvement and up to the lateral pelvic wall. So I think this is FIGO stage 3B.
Sorry to interrupt you, as per FIGO 2018, we are supposed to take, not just do clinical staging, but take help from the radiology also.
We have to take.
Yeah. So clinically, we cannot assess the pelvic lymph nodes, but the disease was extending to the medial 2/3 of the parametria. So as per that staging, she is definitely 2B. But
and
then
second thing for the nodal staging, for the nodal staging, I think.
Just a minute. FIGO staging has been changed. So if radiological pelvic node is suffix as R, if pathological the suffix as P. So it is changed now.
So we just did the imaging. So we did not do the USG or imaging guided biopsy of the pelvic nodes. So it's still 3C1R just with the imaging by MRI.
And I think for nodal staging also, you need, I think, PET CT or CT scan, because PET CT is more sensitive to detect the paratic nodes as compared to your MRI. MRI, I think, for local soft tissue and extension to the para. MRI is best, but for nodal staging, I think you need PET CT also in this patient.
Points to be well taken, sir. But there was no suspicion on the MRI that para-aortic lymph nodes are involved. So already it was 3C1, and then even if there would have been any suspicion, we could have sent the patient definitely for the PET CT to assess for the distant metastasis. But with positive pelvic lymph node, she was definitely non-surgical candidate. So rather than trying to convince the patient for the PET CT, she opted for.
No. It will help. It will help the radiation oncologist to determine the field of radiation.
Yeah,
because they include the para-aortic field also.
Because since right now we don't have the radiation facility, so if Rajiva sir would have planned to do that, he would have taken the PET CT in consideration, whether she needs just EBRT brachy with concurrent chemo or extended radiation to cover that para-aortic nodes if that was positive on PET CT.
Just like to intervene. We truly agree with you. PET CT is the modality of choice for para-aortic dissection, and that was one of the plans in this case. Thank you so much, Dr. Ritu.
Any further questions from the house?
No, it's all right. I am Dr. Khandelwal. I enjoyed your case presentation in which all the interplaying, radiologist, radiotherapist, pathologist, everyone, this is the way case should be presented. I like that. My question, which partly raised by Dr. Ritu Sharma, is still unanswered. Everyone is focusing vaccination, but we know the incidence of CS cervix decreased in India also. What to talk of Australia, where it is very much less. So actually the main credit goes to water, hygiene and sanitation. But we are so much brainwashed by the vaccination company that we talk only and only of vaccination.
Any questions from the house? Any insights? Dr. you want to say something? Oh, yes, please. Just a minute. There is a comment.
Is elimination as a public health problem?
So thank you, sir. Thank you for the
just for my conclude this. May I conclude this lecture now? Cancer cervix is almost a preventable disease. The first is vaccination, but the effect of vaccination part will be evident later. It is not yet evident, and you can't expect that within 10 years or 15 years we are going to see any positive effect of the vaccination. At the present, in the present scenario, the second is our inspection and clinical examination of the patient. That means screening. For screening, visual examination is possible for all women all over the India. It is not at all difficult because there are many gynecologists spread all over the country, and they can be given a task of examining a definite part of the area may be allocated to them to examine women and to find out whether their cervix is normal looking or abnormal looking, and to try for getting pap smear for all women who are sexually active. That will be very good. But even if it is not possible, then to do pap smear of at least those in which we get unhealthy cervix. So this is the second step in preventing it. The third is early diagnosis. And for early diagnosis, women must be made aware of the signs and symptoms, although unfortunately the symptoms and signs in cancer cervix, they get late, and the patient may not be able to complain anything before it is too late. So only examination can rule out whether she is developing cancer or not. And the third is early diagnosis, and the fourth is if the diagnosis has been made, or if the diagnosis has been made late, then proper treatment of the patient. So all these four stages need to be emphasized to eradicate cervical cancer. And it may be a matter of, it is not a good thing, but at least I feel that if someone has noticed that the cancer cervix incidence has decreased, it is not the effect of vaccination. It may be an effect in our area at least, the effect of hysterectomy, which is being done at every nook and corner of the country by everybody who is removing the uterus and saying that you may get cancer later and you must get it removed. And the women are getting hysterectomized every now and then. Many women are sacrificing their history in the name of cancer. So thank you very much. And this lecture was superb by Dr. Sarita.
Thank you, ma'am.
Just but there are only few etiological causes for cancer, and HPV DNA is one of the most important thing. So it is not only causing cervical cancer, but it is also a common cause for oropharynx. So the vaccination schedule is not for girls only; it is also for boys. So it is one of the most important thing to consider that every child is now getting vaccinated with this, because in Western countries the incidence of CA oropharynx is constantly increasing with this virus. Yes, thank you.
Might be the vaccine Servavac, which is recently gonna come in the Indian market, which will be easily accessible to and not with much financial constraints, will be in a better position. I think so.
Thank you.
Thank you, ma'am.
Thank you. Especially from all of these categories. We're just sitting over here, and Dr. Shukla just wanted, Dr. Shanti Roy's dream and vision. So maybe in the near future, Medanta can collaborate with Dr. Shanti and Dr. Shukla for the screening program that you just highlighted. And for you, ma'am, 25 years of legacy, the handloom which you're wearing, from a husband to a wife, and from a wife to a daughter.
Yeah.
That's a great emotion.
Thank you very much. Thank you.
Big round of applause for ma'am.
Thank you.
Let's have our next speaker on stage, Dr. America. Recent advances in the management of accident and customer risk. Can I request Dr. Shukla to kindly read the introduction? Introduce
Yeah, it's my pleasure to introduce Dr. Niharika Roy, who is a senior consultant at Jayaprabha Medanta Hospital in Patna. She has done fellowship in breast oncoplastic surgery from Tata Medical Center in Calcutta. She has done MS in surgery. She has performed over 3,000 breast surgeries and is a trained breast surgeon specialized in surgical care of breast diseases, especially in cases of breast cancer with treatment like MRM, breast conserving surgery, oncoplastic breast conserving surgery, sentinel lymph node biopsies, and excision of stereotactically localized lesion, guide wire lesions, etc.
Thank you so much, ma'am.
Yeah.
For such
Please,
a nice
yeah. We'd be very happy to hear your talk now.
Thank you so much, ma'am. It's very nice speaking in front of Madam, Santi Madam and Sushma Madam, Sipra ma'am, and Dr. Ridhu Sharma. And actually, okay. So, I would like to introduce my team. I cannot do anything without my team. This is the first thing I would like to say. It's small, but I think it's very large, and it is dedicated to all the women of Bihar. As we can see, there is a change in from the beginning of the management of axilla from the Hallstadian era to the new millennium. In the previous period, it was that complete from level 3 to level 1 clearance was there, and then total mastectomy was there, but nowadays the radical mastectomy is there, followed by that lumpectomy is now the more increasing one, and with axillary clearance we better go for a sentinel lymph node biopsy. So this I would like to show this in my next slide. Aim of these changes were to refrain over diagnosis and over treatment as well as their harmful side effect and extra cost. So we can see in this slide, there was radical mastectomy which we used to do in the Hallstadian era, and then now we are more promoting towards the breast conservation surgery from level 3 to level, actually we decide on the level of number of nodes that we take out. So now that sentinel lymph node biopsy is more upcoming thing, because breast conservation, lumpectomy and sentinel has become more increasingly accepted all over world in early breast cancer when the node is negative. So this we can see in this image. There is post-axillary clearance lymphedema present in this patient. The scar we can see, it's the scar and the morbidity through which the patient goes through. It's very painful. That we can feel when the patient says, we cannot lift the arm. How can we get rid of this? It's many a time patient comes to us saying that it's very painful. So if had this been an early breast cancer, node was negative, better we had opted for a sentinel lymph node biopsy. This is what I wanted to present in this picture. So about 50% of the sentinel lymph node positive cases are only 50% are sentinel lymph node positive. Rest of the 50% in this data we can see it's sentinel lymph node negative. So maximum of the early breast cancers, if T1A, T1B, T1C to T2, 50% are sentinel lymph node positive, and the rest 50% are sentinel lymph node negative. So in that case, if we could get this morbidity, the axillary clearance, we could reduce to sentinel lymph node biopsy with a simple incision, then we could get rid of the complication like long hospital stay, long scar, morbidity and extra cost. So coming to the definition, sentinel lymph node is initial node that drains the lymph and the tumor before draining the subsequent nodes. That is the not sentinel lymph node. And it was in the beginning, the first time done in a case of a penile cancer and melanoma. Now it is increasingly being used in the breast cancer cases as well as endometrial cancer.
So it was first time in done this sentinel lymph node biopsy in a breast patient was done by Gullian and his colleague, and he first time used the sentinel lymph node blue dye, methylene blue. But the sensitivity and specificity after going through the data that we will come later, generally we use dye and radioisotope were used to map the draining of the lymph nodes. So there were various trials like NSABP4 during 1970 to 74, and that it studied that if the clinically node negative patient is there, it's better to avoid axillary clearance, and the purpose either clinically node negative or node positive. This was the study, but till after 50 years still the patient are having axillary clearance even though clinically they are node negative. So this is the study that it was done on 1000 patient, 1079 patient. It was clinically node negative, randomized, and the three group were actually taken: radically mastectomy with axillary node clearance, total mastectomy with radiations, total mastectomy with delayed axillary lymph node clearance, and later clinically positive lymph node developed. In those cases where clinically node, later it was node positive, then they did this delayed lymph node negative. And then in a 500 cases about clinically positive node randomized to radical mastectomy with axillary lymph node, and it was compared with total mastectomy with post-op radiations. In the study, they saw there was no overall survival in between 10 to 25 years, whether the patient went for total mastectomy with node negative, or if it was total mastectomy with radiation. So this is what we see in this. Overall survival is 10 to 25 years, identical among node negative arms and also between two node positive groups. So, but even though after 50 years it has been forgotten, now also surgeon do axillary clearance, even though clinically it is node negative. So inclusion and exclusion criteria: clinically, if the patient has no clinically lymph node palpable in T1, T2 disease, it's better to be included. And if it is an exclusion, then in that case, we don't do sentinel if it is clinically palpable, or there is a multifocal breast cancer, or patient is pregnant, or currently having breastfeeding, and prior major breast surgery or axillary operation has been done. Allergies to blue dye or radiocolloid, patients are generally not given this sentinel lymph node. And if it is a DCIS cases, then in that case, if the tumor is more than 5 centimeter, or it is a large lump, or in that case if it is a high grade comedian necrosis, then we go for this sentinel lymph node. Otherwise, if it is the incidental finding in DCIS, then generally we don't do sentinel lymph node. And the technique, coming to the technique, 1 ml of methylene blue is injected subcutaneously into the upper outer quadrant near the areola or periareolar in the tumor. And after 10 minutes, ICG dye, actually dual dye technique is used. The ICG is injected around the areola of the affected site, and massage is done for 2 minutes. And after that, with probe, fluorescent probe, it is actually traced, and the lymph node is dissected out and sent to the pathologist for the comment on the sentinel lymph node. So this is the dye, methylene blue and ICG. This is under the fluorescent camera, which is green and methylene blue. We do this. This is technetium 99M, radioactive. Generally, it is done on the morning of the surgery or before, one day before in the evening, and then it is sent to the OT, and after that we see maximum probe radioactivity about 10% of the tumor, and then we take it out and then send it to the pathology department. So SLNB results are very important for staging of the axilla, and generally dual dye technique is used, and number of nodes is very important. Maximum 4 nodes generally we take out, and accuracy reaches up to 93 to 99% in dual dye technique, and false negative reduces to 5 to 10% in case of dual. And if it is sentinel lymph node is negative, then we don't do axillary clearance, so we could avoid this morbidity. And if it is positive, then we go for a sentinel lymph node clearance. In cases of micrometastasis, there is no need to do axillary dissection. And it's not that it is not doesn't have any side effects. It can be a blue urine for 24 hours. There can be skin necrosis, lymphedema, numbness, and false negative rate are also possible, 5 to 10%. So I would like to discuss a case in this scenario. She was a 45-year-old female, and she had her family history was very high. So her grandmother had a breast cancer. She died of a breast cancer at the age of 50, and she was very worried about it. She ran with multiple centers. There they found on the mammogram and ultrasound that it was a BIRAD 2. So then she came to our center. Here we did the MRI, and in MRI we would like our radiologist, because we have a tumor board each and every time we have a case here. So I will request Dr. Ranjan, please, could you please comment on this?
Again, I'm here to briefly give you the idea about role of MRI in breast lesion. MRI is the most sensitive modality to pick up a lesion in the breast as compared to the available modalities, other modalities like mammogram and ultrasound. So in this case, BIRAD 2 was given on mammography and ultrasound, and then patient came to our hospital to the Dr. Niharika, and she gave the history that my grandmother died of breast cancer. So MRI breast was advised, and we did MRI last month, and this is the finding. So brief view about the indications of MRI in breast. So there are 3 indications: staging in known CA, screening in women at high risk, and assessment of response of neoadjuvant chemotherapy. So in these indications, we can advise MRI. This is the history you already know. This is the images you see. This is the stir axial images. Left breast, you can see 2 lesions. One is small, one is moderate size, well defined. This is cystic lesion. This is solid lesion in left breast. So these are giving the appearance of benign features, and one is cyst, one is fibroadenoma. If you see another, right breast, there is a 7 into 8 millimeter size lesion, heterogeneous, ill-defined, margins are speculated, and very small lesion. It was missed on mammography, it was missed on ultrasound, and this is the contrast enhanced images showing the enhancement. So we did retrospectively, we took this patient to the ultrasound, tried to localize the lesion, and we could localize the lesion. Lesion is very small, isoechoic to the rest of the gland. Then we did biopsy, and in biopsy, it was turned out to be malignant. Now over to the Dr. Niharika. Thank you very much.
It was wire-guided localization along with wide local excision was done, and it was sent to the histopath department. It came out to be a radical scar / IDC, and then we sent it for histopathology. I think Dr. Ashumi Gupta will comment on this for IHC and this one.
Good morning, everybody. We got a wide local excision specimen of the lump which was excised. It was around 5.5 into 5.5 centimeter lump, and inside there was a small area around 1 into 0.5 centimeter which was whitish, and the rest of the area was fibrofatty. All the margins were grossly uninvolved, and then when we saw the sections, they were compressed ducts and a few cord-like structures which was embedded in fibroelastotic stroma. The peripheral ducts showed some usual ductal hyperplasia and columnar cell hyperplasia. So we kept a suspicion of radial scar and to do IHC to rule out the possibility of invasive duct carcinoma, because in such cases only the presence or absence of myoepithelial cells can actually point towards an actual diagnosis. So the immunohistochemistry was done, which came out to be ERPR positive, HER2 equivocal, and Ki67 was 10 to 15%. The myoepithelial markers were negative, which included P63 and CK5-6. So the case was diagnosed as invasive mammary carcinoma.
Yes, so the management part, yeah, you stay here only. We'll just. And then we went for sentinel lymph node biopsy, and it came out to be negative. So we didn't do the axillary clearance, and the patient was then discussed in the tumor board, and it was planned for radiation along with hormone therapy. So I would like Dr. Ashumi to comment on the sentinel lymph node pathology of the patient.
So the sentinel lymph node biopsy report in this case was negative. So that was what actually detected the future treatment of this patient. So sentinel lymph node biopsy report is extremely important in deciding further management, as we can all see. So as soon as the patient specimen comes to us of the sentinel lymph node, the important part is to gross it very, very carefully. The lymph nodes are dissected out properly, and then they are enumerated, that is whether they are single or multiple. And then the lymph nodes are bisected along the longitudinal axis, and the cut surface examined for the presence of any gross metastasis, which usually, in contrast to the tan cut surface of a normal lymph node, will be whitish and firm in texture. During the dissection, the surrounding adipose tissue, a part of it is preserved to be able to comment upon the extracapsular extension, which is important for further staging. So the lymph node is measured and cut along the longitudinal axis into 2 millimeter thick sections, and imprint cytology can also be prepared, which can serve as adjunct to this diagnosis. So this is just a diagram showing how it is cut. So the lymph node is cut along the long axis into 2 millimeter thick slices, and this helps us to diagnose most of the macro metastasis, which means that the tumor nodule within the lymph node is more than 2 millimeter in size. So when we cut 2 millimeter thick sections, we can actually diagnose all those, and this is how a histopathology tray which contains the slides would look like, and this is just to show you a photomicrograph of this. So why is it important to cut it along the long axis? Because the afferent lymph vessels enter the lymph node along this axis, and also it allows us to see the subcapsular sinus, the lymph node sinus, and the capsule properly. So one full section should come in the H&E sections, which enables us to see the entire lymph node. So this is how a slide in the department looks like. So this was a case of sentinel lymph node which came to us and was reported as positive. So we can see that this highlighted area inside the red, this is the tumor, and the rest of those, the blue area, if you can make out, that is the lymph node. So rest are slightly higher power sections that can help you see. So below is the high power view. You can see that these epithelial cells, they have pleomorphic nuclei, and even mitotic activity is there. So apart from tumor cells, we can also have certain non-neoplastic cells in the lymph nodes, such as these brown cells in the right low figure, if you can see. So these are macrophages which can contain certain pigments like hemosiderin or melanin-laden macrophages, which we should be aware of to avoid false diagnosis. So the report of a sentinel lymph node biopsy should contain the number of lymph nodes that are totally dissected out of the specimen, the number of lymph nodes which are positive for metastasis, the largest contiguous focus of the tumor in the lymph node. So this can be measured by means of the scale which is there in the stage of our microscope, or if we have a digital scale by means of a software where we can see it on the desktop. So, and also an important thing is the extracapsular extension, that is when the tumor has moved beyond the capsule of the lymph node into the surrounding adipose tissue. So whether it is present, absent, indeterminate, and if it is present, the largest extent can be documented. The metastases are classified into macrometastasis, that is any tumor deposit more than 2 mm, micrometastasis, which is 0.2 mm up to and including 2 mm in diameter, that is more than 200 cells. So if macrometastases are present, the micrometastases are counted and added to find the final N category. And if only micrometastases are detected, then it is classified as PN1 micro. Then isolated tumor cell clusters are very small clusters which are not very large, that is not larger than 0.2 mm, or even single cells or less than 200 cells. They may be detected by routine HE, or sometimes they may show up on step sections or on immunohistochemical techniques. They are not included as of now in the total number of positive lymph nodes when determining the PN category. So sometimes we can have false negative sentinel lymph node. Usually in patients that undergo sentinel lymph node biopsy, that is a first draining lymph node. But if there is a deviation in lymphatic supply which can occur in case of previous surgery which leads to fibrosis or unusual lymphatic drainage. Now what happens is when the sentinel lymph node is completely replaced by the tumor, sometimes there may be deviation of the lymphatic supply which may lead to a false negative lymph node. Then frozen section analysis is accurate and efficient means of rapid SLN assessment, and it allows the axillary lymph node resection to be completed in a single setting. The mean sensitivity in the literature is reported to be 73% and specificity is 100%, and it is more reliable for detecting macrometastasis than micrometastasis. But as already told by Dr. Niharika, it is not so important. Even if it is not detected in an intraoperative setting, the clinical significance is not so great. So limitations of the sentinel lymph node biopsy include non-ductal type of mammary carcinoma, for example, lobular carcinomas, in which the features may not be so clear and we may need IHC, etc., to be able to achieve the diagnosis. Then metastasis from extramammary, that is outside breast, if we have a primary and that metastasis to the sentinel lymph node. In those cases, which are rare although, but we should be aware of that, and lymphovascular invasion. So routinely step-level sectioning or the IHC is not recommended as of now in the current CAP protocols, but they can be used to confirm uncertain findings. So usually used antibodies are against pancytokeratin, CK19 and CK7. Although the adjuvant treatment, that is chemotherapy or hormonal or surgical therapy, should not be made solely upon the information obtained by IHC of the sentinel lymph node. And at the same time, we should be aware of the false positive that can show up on immunohistochemical techniques, that is the benign breast epithelial cells or sometimes the macrophages, they can take up the cytokeratin stain. So only in the light of HE staining, we interpret the IHC. So molecular analysis is another next steps technique that includes RT-PCR and one-step nucleic acid amplification, but they have a lot of false positive and negative due to variable results, and it cannot be extrapolated correctly to the amount of tumor metastasis load which is clinically significant. So it is not used routinely and only more for research purposes. So micrometastasis or occult metastasis that are not identified on initial examination, there is not much difference in the overall or disease-free survival. So even if they are not detected in the intraoperative setting, so we need not to worry too much over that. So sentinel lymph node biopsy report is extremely important in managing the cases of especially the early carcinoma breast, and careful gross and microscopic examination in good hands leads to diagnosis in most cases. So we have been doing this biopsy reporting for the past more than 1 year in in rapid with the surgical oncologist and Dr. Niharika for the breast, and so we look forward to doing more and more such cases. Thank you very much. Over Dr. Niharika.
Thank you so much. Ashumi? Done. Any questions? Yes, sure.
Hello, thank you very much, Niharika, for the very nice and informative presentation.
Thank you.
And due to the modern new modalities and the public awareness regarding the breast, because each and every woman at least always palpate her breast, and even for the pain in breast, lump in breast, or if nothing, then only they can also come and say that, Madam, please see my breast. I have a family history of carcinoma breast. So by these things we can prevent the carcinoma breast, and we can early detection of the breast carcinoma is very common. And nowadays due to radiotherapy we can also cover the axillary portion. So just if the sentinel lymph node are not positive, then it is good, because after the removal of sentinel lymph node there may be chances of lymphedema you have shown in the first slide, and that is very painful condition, and it occurs about in 30 to 40% of the cases. That is the disadvantage of opening the axilla.
Yeah.
Okay, thank you very much.
It causes morbidity, ma'am, if the axilla is open.
Any question, please, from the audience?
Yes.
Yes, actually I have got few points to comment on.
Yes.
The first thing, it's okay. Basically, you told that this was a case, you discussed that she was a lady 50-year-old and she was having a family history.
47, yeah.
40 age group. So family history, the thing is BRCA testing should always be done in a patient who is having a family history of breast cancer.
Yes, true.
Because the treatment and all that depends. The second important thing is MRI. MRI, as far as staging is considered, we should never consider MRI for the staging purpose.
No, it was for detection problem.
For yes.
She was in high risk case. So
High
we
risk
went
case,
for
yes.
MRI
This was
breast.
yes. And
So
only
because
MRI
yes,
for
ma'am.
high risk case, a patient who is having a lifetime history of more than 20%. It's not only MRI that is to be done, but these things I should highlight to everyone that mammography, MRI is not a substitute for mammography. You should do it MRI as well as mammography, and the time interval should be 6 months between these two investigations as far as screening is considered. The second thing is, as you discussed, what was the size of the tumor? Why not chemotherapy was given to this patient?
Because the NPI score was 2.2. So it is a good prognostic index. So in that case, we generally don't go for chemotherapy.
But the size of the tumor, what was the size of the tumor?
0.8 centimeter.
0.8, it was 8 mm.
Yeah.
Okay, I thought it's 5 centimeter.
No, 0.8.
And the third important is sentinel lymph node. It's
Yes.
only not one positive, as Dr. Shushma Pandey has rightly told.
Yes.
A patient who is planned for adjuvant radiation, it's always up to 3. The recent trial have said that if sentinel lymph node up to 1 to 3 is positive, we can spare axillary dissection, because radiation will take care of those axilla which is not
addressed.
Yeah.
Yeah, true.
So thank you so much.
Actually, even we have data also. After doing the sentinel lymph node biopsy in early stage breast cancer, you have done lumpectomy along with the sentinel lymph node biopsy. Now you have 3 subset of patient. One with the sentinel lymph node negative. Then again we have data from NSABP32, nothing we have to done. We can avoid the axillary clearance. Second subset of patient, you have 1 to 2 lymph node positive. In that case also we have data from the several study that we can avoid the axillary lymph node dissection.
Yeah.
Patient can be radiated after the lumpectomy. We have to SPR the axilla, no radiation to axilla or no axillary clearance. If 3 or more node positive, then we can go with axillary node dissection.
No, she was a high risk. Yeah, that's
It has to be done only for certain indications.
Yeah, high risk.
One is for BRCA positive patient, the guidelines actually. And the other thing is the patients who present with axillary lymph node but no primary is there. Third is when you are suspecting a recurrence and you want to differentiate the recurrence from the scar. Fourth is when you are dealing with case of lobular carcinoma. And besides that, it should be avoid MRI because there is high chance of high false positive. So you should avoid that. But for, as Dr. Vyarika said, for patients who are high risk of in the family, there you can consider.
That was she was done. Because outside it was not picked up, it was BIRADS 2.
Why chemotherapy was not given? Because see, the tumor was less than 1 centimeter.
Yeah, it was NPI score was low.
It was ERPR positive, so it was
Point. Yeah, it was given on MRI.
less than a centimeter size.
Yeah. So NPI score comes out to be less than 2.2. So it's a prognosis. NPI scoring is low. How we could have.
I'm not saying that MRI is the mammography, but mammography retrospectively I have inquired, there was no lesion. Even retrospectively on ultrasound I took the patient for with difficult attempt I could visualize that lesion. So in a high risk patient you have to decide which patient is high risk, but in high risk patient MRI is indicated because MRI has no radiation. So MRI is very safe. You can do MRI in a number of.
Yeah, it's not exposed to.
So I also agree that MRI should always be done in all those high risk cases.
Yes.
When the lifetime risk of malignancy is more than 20%, I don't disagree with this. But for only MRI should not be done for all those cases. MRI.
No, she was a high risk. She had
this case I totally agree.
Yeah.
MRI was done to detect cases in a very early disease. So I totally agree that MRI should be done.
That's true. That's true. Thank you.
So, I have one more query. Yeah. So in this case, are you happy with NPI, or you move forward with, or you advise oncotype DX, because the patient is having a family history and the BRCA mutation is unknown? So do you advise for an oncotype DX?
Was done. Actually, in recently only that we had diagnosed, and we are planning for radiation and hormone therapy and oncotype. We can assist. Actually, we are.
So usually, are you comfortable with NPI, or you advise for an oncotype DX before avoiding chemotherapy?
Pardon?
Are you comfortable with using NPI, or you
NPI
advise for an
scoring and oncotype DX, both of them.
Exactly. So that's what, before avoiding chemotherapy, I mean, oncotype DX is very important.
Yes. Thank you so much.
Thank you.
Any further questions from the audience? In the house, any questions? Dr. Sandeep, do you want to add anything? You still have, we've got 2 minutes. You can use it. Any questions?
Thank you very much.
Now we come to the end of the session.
Thank you very much for inviting us as a chairperson. Thanks a lot.
It's a pleasure not to have the doyens of, Obs sitting right in front of us. Big round of applause. Big round of applause. We move to the, you want to ask something? Oh, please. Can we just escort? Ma'am, listen, ma'am, just a minute. Dr. Ajay, sir, ma'am, you can see over there. Ma'am, the other doyen, can we just, felicitation, can we have felicitation, please? I mean, who better, I think, than Dr. Ajay to felicitate? It's a, no need to come. Ma'am, यहाँ पे खड़ी होती है, इसलिए वहीं से शुरू हो जाता है. सही है मतलब. Okay, can we start with the felicitation? Yeah, please. Yes, please come this way. Come this way. Ladies and gentlemen, Dr. Shukla Roy, Dr. Ajay, sir, please. I'm so sorry, Dr. Shanti. Dr. Sushma Pandima. Coming on a Sunday morning, spending time with us, it's such a privilege, ma'am. The ever smiling, young, beautiful Dr. Shukla Roy, now please. Such a privilege for a teacher to a student. Dr. Sangeeta, ma'am, you two need to be felicitated, so please collect it with you. And Dr. Sangeeta Sharma, in 25 years of activity in California today. The applauses are died. Come on. Enlighten me. Dr. Lidu, please. Please be most embarrassing. The other person, please be ready. Dr. Niharika Rao.
डॉक्टर दीपक सर वो बैठे हैं
Thank you so much. There's just been an alteration in the program. Dr. Deepak Singh sir is going to fly today. So we're just reporting this program. I'd like to take the privilege of introducing Dr. Deepak Singh. Sir has been sorry for the confusion. That is Dr. Amrinder. Dr. Amrinder. Yes. Okay. So let me take the privilege of introducing my good friend, senior colleague, Dr. Amrinder, a senior consultant, medical oncology in Jaipur, Medanta Super Specialty Hospital, Patna. He's completed his MD in Clinical Medicine from St. George's Medical University, Lucknow, and DNP Medical Oncology from Apollo Hospital, New Delhi. He's been in ICMR, shock and resection in his MBBS days, and his specializations include treating prostate and breast cancers and administering immunotherapy and targeted therapy. Also, an expertise in treating GI, liver, lung, head, and lung malignancies. He's also received the Indian Council of Medical Research, the ICMR, Shock Institute Award during his MBBS in the year 2004. Along with that, he's received the Best Presentation Award at the 13th International Conference in Thailand in the year 2018. One of the expert panels of American Society of Clinical Oncology, Education and Growth. Also, reviewer of the Journal of Thoracic Oncology and the Journal of Support Care and Cancer. Can I have the panelists on stage? Dr. Lee, you're supposed to chair, you're one of the chairpersons, so please can you come on stage. This part, can I also request Dr. Arvind Kumar, medical oncologist, Buddha Cancer Center.
He's coming.
Yes, Dr. Arvind. Can I also have on stage Dr. Avinash Upadhyay, medical oncologist. So Dr. Amrendra is going to talk about the geriatric oncology and palliative care in there of personalized medicine. Over to you.
Good afternoon, everybody. मेरे साथ टीम नहीं है, जैसे पहले बाकी दो के पास टीम थी, मेरे पास टीम नहीं है, बट मेरी टीम मेरा पूरा हॉस्पिटल है। और आप लोगों से मैं थोड़ी विनती करूंगा कि मुझे इंग्लिश के अलावा थोड़ी हिंदी में भी बोलने की इजाज़त दी जाए और कभी कभी संस्कृत में भी बोलने की इजाज़त दी जाए। सो थैंक यू सो मच। So topic for today is geriatric oncology and palliative care in the era of personalized medicine. So what is personalized medicine first? So personalized medicine is something which you can call as a very targeted treatment, a customized treatment, or maybe tailor-made treatment, or in a better word, precision medicine. So precision medicine, that will be dealt by my friend Amit in the later half of this session. So precision medicine is something where you target a particular molecule by finding it out on various platforms, various tests, and one of the most recent is NGS, next generation sequencing. So that is an era of personalized medicine. Now हम में से बहुत लोग हैं जो कि गांव घरों से आते हैं, तो उसको मैं बोलूँगा कि पर्सनलाइज मेडिसिन क्या है। उसको समझाने के लिए मैं ये बोल सकता हूँ कि अगर आपके गांव में आम का पेड़ है और एक आपको पका हुआ आम दिख गया, तो एक ढेले से उसको जब मार के गिराते हैं तो दैट इज प्रेसिजन मेडिसिन। सो सिमिलरली लाइक इन मेडिकल ऑन्कोलॉजी, और यू कैन से कि अच्छे टर्म्स में बोलेंगे तो सर्जिकल स्ट्राइक, गए और वहाँ ऐसा मिसाइल छोड़ा कि भाई सब कुछ खत्म हो गया लेकिन अगल बगल वाले बचे रहे। So surgical strike. So in the era of personalized medicine, do we have some role for personal touch, the healing touch that our CM was alluding to yesterday? Do we have? Second thing, our director Dr. Ravi Shankar Singh, just a month back, he shared with us an article where it was mentioned that we should evaluate the patient as a whole. There should be a wholesome treatment and not just one treatment, so that we miss the forest for trees. So is there any scope for healing touch or personal touch in the era of personalized medicine? So going forward, before we discuss that thing, geriatric and palliation, what are these words? So Merriam-Webster, geriatric, it says that a branch of medicine that deals with problems of diseases of old age and the medical care and treatment of aging people. And it is so smart that it also says an old family member is often the inspiration for medical students who choose geriatrics. And we all of us have some old person in our family, and we will be old in some time. So let's not forget that geriatrics is a very important part. And when we talk of geriatrics, generally in common parlance we say elderly people. Now elderly people is something which you give an umbrella word to all these people, and that may not be the right word for all these people. Now the term is older adults. Now second, palliate. What is the palliation? So palliation is to reduce the violence of a disease. Second, to cover by excuses and apologies. कई बार पेशेंट आते हैं तो हम लोग प्यार से भी समझाते हैं, उससे भी पैलिएशन होता है. And to moderate the intensity of whatever the symptoms are. So geriatric oncology is something which deals with the cancer of older adults. Now, when we talk of older adults, we doctors generally want to see the patients who are generally fit. Those can be treated with good outcomes, and we generally believe that these people will be young. And that is true with the trials also. The trials include people from 20 years to 60 years. Now the trials are coming up which include people till 70 years of age also. But what about 70 to 80? What about 80 to 90? Would they be left to die when they are diagnosed with some serious disease? I should say not. So looking at this data from Globocan. Globocan is an online platform by World Health Organization, and you can see there is a crude incidence rate, and I have projected the crude incidence rates above 55 years of age and below 55 years of age. You can see upper bar shows the breast cancer, the rate of breast cancer, whereas all the bars they show us prostate, lung, and so on and so forth. So you see that the crude rate incidence rate generally increases with age, and it increases after 60 years of age. So you can say that cancer is a disease of older adults. And when you are saying this, and when you are believing that the cancer would be there in the young people so as to make you comfortable with the treatment, then we are compromising on an Indian ethos, and that is Sarve Bhavantu Sukhina Sarve Santu Niramaya. Ma Kaschid Dukh Bhag Bhavet. That means even older adults have the right to not to suffer. Not just young people, not just pediatric ones. So this is the data. Now classification. So you might not be aware that old age is classified in 3 different certain categories. Young old is 60 to 70 years, old is 70 to 80 years, and oldest old is more than 80 years. Now I would like to add one more category to that, because this category is by American people, and we have visualized in our scriptures Jivet Shraddha Satam. That means one should outlive at least 100 autumns. So if that is our vision, there should be one more category, and this oldest old category should be converted into older old, that means 80 to 90, and there should be one more category, oldest old, more than 90. And then when we categorize this, maybe we will achieve Ma Kaschid Dukh Bhag Bhavet, let there be no suffering to anyone. So what are the facts? In 2050, 80% of older people will be living in low and middle income country. India is one of the middle income countries, and it is not going to be there in high income countries till 2050. So look at this data, how scary is that? The pace of population aging is much faster than in the past. In 2020, as rightly projected in the first slide, the number of people aged 60 years and older outnumbered children younger than 5 years. Between 2015 and 2020, the proportion of world's population over 60 years will nearly double from 12% to 20%. That is a huge data. So what is unique with this age group? Now we all have seen that a 60-year-old may look like a 50-year, a 60-year-old may look like 80-year, and an 80-year may look like a 60-year. So what is that? What is that which makes a person look like 80 years even at the age of 60, or look like 60 at the age of 80 years? So there are some geriatric syndromes which should be looked into while deciding the treatment. So whenever a patient, an older adult patient, comes to our OPD, we must examine him thoroughly, him or her thoroughly. So what are these unique syndromes which are associated with older adults? First one is falls. You must take the history of falls. Sir has already enlightened us about rheumatoid problems, arthritis and all. These are the contributors of falls. So how can we say that this person is under high risk of fall? A very simple test, timed up and go test, TUG test. You just ask the patient to get up from the chair, walk for 3 meters, turn and then get back to chair. That will give you. So there are certain trials, there are certain things. We say that the time taken should not be more than 16 seconds. And if it is more than 16 seconds, that person is at high risk of falls. And when a person sustains a fall, then it leads to a cascade of events which leads to depression also, and the patient may not survive for long, and that is proven. Then cognitive impairment. Cognitive impairment, we know that sets in roughly beyond 60 to 70 years. And how can we assess that in the OPD? Very simple test. You just draw a clock and you ask that older adult to read that clock, or just read them 3 words and ask them after 5 minutes what were those 3 words. So cognitive impairment. Polypharmacy, that is very important. So polypharmacy by definition is generally accepted as administration of more than 5 medicines. So if there is history of polypharmacy or the patient is taking more than 5 medicine, you should ask you should ask yourself, I should ask myself, whether this is appropriate or inappropriate. There are, Dr. Suraj tells me all the time that एक patient ये वाला शेलकाल भी खा रहा था, उधर कोई और भी खा रहा था, सीसीएम भी खा रहा था, एक और कुछ भी खा रहा था. तो these are inappropriate. बट वो होता नहीं है, वो चलता ही रहता है, हमें देखने की फुर्सत नहीं है, मुझे देखने की फुर्सत नहीं होती, मुझे देखने की फुर्सत नहीं होती कि सीसीएम खा रहे हैं कि शेलकाल खा रहे हैं कि क्या खा रहे हैं. चलने दीजिए जो आपका चल रहा है. सो एक ही दवा 3-3 बार. सो इनअप्रोप्रिएट. एंड वेदर दिस इज अप्रोप्रिएट, so there is a criteria, BS criteria, and that includes whether this medicine should be given at this age or not, whether this is counterproductive for that age, whether it has got some interactions with few medicines. So there is BS criteria. So we can just go into the app and calculate whether there is inappropriate or appropriate prescription or not. And then depression, obviously, old age, loneliness, no social support, then it leads to depression. So I will rope in my psychiatry and psychology colleague to look into that. Please give me 3-4 minutes. So UN Decade of Healthy Aging, it says this decade is UN Decade of Healthy Aging. So it says that we should change how we think about age and ageism. Now ageism is not a right word. Along with all the isms in this area, ageism is also a bad word. We should not promote ageism. We should develop communities in ways that foster the abilities of older people. So here my team will be community or society, not just 4 or 5 persons. The hospital, the family members, the community, the society. And deliver person-centered integrated care and primary health services responsive to older people. Primary health services responsive to older people. We are stuck at ICDS, Integrated Child Development Services, and Anganwadi workers. But who is taking care of our older adults? So I leave you at that question. So I will just go into a little detail about palliative care. Palliative care, obviously we generally in India look at palliative care because this is for postgraduate students who are here. When we treat the patients, cancer patients, we treat them with either curative intent or palliative intent. Curative intent is like complete elimination of cancer, and palliative is prolonging life or giving respite from their symptoms. So generally it is seen that up to 60% of persons in India, they come with advanced diseases. So only option left with a doctor is to give palliative care. Now palliative care is generally used with supportive care also, and supportive care can be given even in early cancers also. And as they say, charity begins at home. So the palliation should also begin at home. And at home means relaxed. So person should be relaxed. And how you relax him? By not telling the diagnosis? No, that is the first fault that we make, that I have made in the past. So if you have to relax a person suffering from cancer, you have to tell him diagnosis. And if you tell him diagnosis, it may be shock for some time, but he or she will recover from it and will fight the disease very bravely. So palliative care starts from there. A good outcome can be achieved only when a patient is comfortable with a treating team. You have to develop trust. I have to develop trust with the patient. And trust, I was talking with few of the postgraduate students in Nalanda Medical College, and one guy told me that the trust develops by making the patient comfortable. Postgraduate student, he told me, and that is the most important thing, I would say. So personal touch is paramount irrespective of the mode of treatment, whether it is surgery, whether it is radiation, whether it is chemotherapy, or whether it is precision medicine. Personal touch is paramount, and even if there is artificial intelligence and all, personal touch will remain the paramount. Take home messages: old age is not an umbrella term, and the patients can have varied presentations depending on the age group they fall into. One should address geriatric syndromes that I have enumerated while initiating any cancer treatment. Palliative care can't be provided to its fullest potential without a personal touch, and the society should grow into a way, in a way so as to enable the population of older adults to lead a life of respect. That brings me to the last slide, and I would say Abhivadan Shilasya Nityam Vridhopsevina Chatwaritasya Vardhante Ayurvidya Yasubalam. One who is a man of integrity, who is humble, and who takes care of old people, his age, his knowledge, his fame, and his power increases. Thank you very much.
Yeah, Dr. Amrinder, thanks for this talk. And to all my colleagues who are not from the oncology field, I would just like to add that in the era of personalized care in oncology, age is just a number. We sometimes say that this chemotherapy we can't give you at 70 years, this radical surgery at 60 years. But era of personalized medicines, most of these medicines are just like tablets, like diabetes or hypertensive tablets that can be taken even at 90 years, or age is just a number. And these medicines, if the target is hit, you have a target or targetable drug is there, then they would do wonder. Wonder means magic. With immunotherapy, we have patients who are cured at 75, 80 years of age. So don't keep this, through this particular talk, I would just give this message that don't keep this thing in mind in today era of cancer treatment, that you are 75 years old, take your parents, give them best supportive care. No, this is wrong. At least get a NGS done to find the target. जैसे इन्होंने बोला ना कि आम खोजो पका हुआ आम किधर है, एक ही टेस्ट याद रखो कि NGS करा कि नहीं, and PD-L1 test for immunotherapy. No chemotherapy, no surgery, no radiotherapy. I am a medical oncologist, I say that no chemotherapy. Stage 4 है, NGS कर लो, get a NGS done, get a PD-L1 done. If the target is there, be relaxed. Even a stage 4 cancer patient at 80 years, he can survive for next 5 to 6 years with a good quality of life, with just a single tablet. So this is the message.
Thank you, Dr. Amreen, for the nice talk. So,
Dr. Amreen, I just like to mention that our medical oncology colleagues are very enthusiastic when dealing with the geriatric patient, because we have so many treatment options. But when coming to surgical oncology, they usually do make barrier to the age. So what should be considered? And I just like to mention above all that whenever deciding any treatment, whether this is from the medical oncology, radiation oncology, or the surgical oncology, we should take care of the quality of the life. This is the main theme. We should take care of this thing. So whenever dealing the geriatric patient, we should communicate well, and we should take into consideration their willing, what they want.
Right.
So communication is the tool for which we should work on. And second thing is the quality of life. We should take care of this thing.
Agreed,
Thank
ma'am. Thank you.
Thank you, Dr. Amreen, for the nice talk. So we have heard about the geriatric oncology. We do not hear about young oncology or child oncology, because geriatric population is a special population. And this comprehensive geriatric assessment which you were discussing, the various domains, I believe that not only helps in deciding the treatment, it also helps when you go through the various domains, suppose nutrition, whether nutrition is fulfilled or not. So you can just intervene and you can make that patient better to take the treatment. And as Dr. Richa suggested, quality of life does matter in elderlies. Regarding palliative thing, I would like to say there are various ways of palliation. You can use radiation as a means of palliation where there is pain. You can use oral morphines. You can use chemotherapy, oral metronomic therapy. And as Dr. Arvind suggested, there are now targeted therapies which can be used just a single medication and that can change the life. So palliation is now, it's a very broad term, not taking care of only the patients, but also taking care of the caregivers which are there. So it's a very broad speciality and which covers for everyone. Thank you.
Agreed. Thanks.
We are talking.
Just one comment. Palliative care is not only limited to oncology. In fact, the largest segment which requires palliative care is cardiology. 38% of patients in cardiology they require palliative care. The second point I would like to make is that in India, in lower middle income countries, in pediatric, 98% of patients are pediatric patients who require palliative care. Is a very big branch, not limited to cancer. Palliative care is a very, very vast subject.
थैंक यू डॉक्टर अमर, आपने हिंदी संस्कृत और बहुत ही अच्छे ढंग से बातों को रखा. लेकिन द थिंग वाज मेनली फोकस्ड ऑन palliation, and palliation is certainly beyond treatment, specific treatment. We need to highlight the, you have not mentioned about the analgesics. Pain is a big thing. Suffering, of course, spirituality also comes in. लेकिन पेन के लिए आपने जिक्र नहीं किया इसके बारे में, द अवेलेबिलिटी ऑफ मॉर्फिन, और डॉक्टरों को सेंसिटाइज करना. यहाँ बैठे हुए जितने लोग, उनको आपको सेंसिटाइज करना है कि मॉर्फिन टैबलेट शुड बी फ्रीली गिवन टू द पेशेंट इफ दे रिक्वायर. ऑफ कोर्स वी आर टू जज. ये चीज़ आपके पैलिएशन में आई वाज जस्ट थिंकिंग कि आपने मिस कर रहे थे. दिस एनाल्जेसिया पेन किलर is definitely to be highlighted as palliation.
So may I add to that, sir? So I was talking
and of course the spirituality parts comes to take care of the suffering.
Sir, I would like to say that it was not about spirituality. The talk was not about spirituality. Sorry to say, sir. And as far as your second question is concerned, so we have made morphine available at our hospital. And I was talking to Dr. Ravikant from Tata Memorial Hospital, and he told me that it would be available freely in Bihar very soon. So obviously that prerogative is.
ये बात मैं इसलिए नहीं कर रहा हूँ कि अवेलेबल है कि नहीं, बहुत जगह अवेलेबल है फ्रीली, अभी भी मॉर्फिन टैबलेट अवेलेबल है पटना में.
Yes, sir.
बात वो नहीं थी. आपका जब टॉक पैलिएशन पर बात कर रहे हैं तो पैलिएशन में ऑफ कोर्स आपको पेन और सफरिंग की अगर आप बात करें विच इज़ द मेन थिंग, तो उसमें आपको स्पिरिचुअलिटी और उसको लाना ही पड़ेगा आपको उस बात को. ये आप ये नहीं कर सकते कि हमारे पैलिएशन में स्पिरिचुअलिटी नहीं आएगी. एट द सेम टाइम पेन किलर एंड सेंसिटाइज टू द पब्लिक एंड टू द डॉक्टर्स देमसेल्व्स regarding the pain is very important. That is what I wanted to highlight.
Thank you, sir. Right, sir.
And as you told about the morphine availability is really a good thing, and lots of big hospitals are having this, and we are working on this that we can reach to the commercial level also. For this, Government has also really worked, and IGMS, Mahavir Cancer Sansthan, Vedanta Hospital, Paras, everyone is having knowledge, and we are running a CCEDC course, which is a certification course at IGMS age Patna, which is training, this is 18 hours of that session, in which national faculty has trained people who are MBBS or nursing. So morphine is not a medication, but palliative care really needs a big
Yes.
Dr. Amar, as far as the morphine availability is, it should not be available freely, first and foremost. If it is available freely, people will start misusing it. So a word of caution has to be attached here. It should be with a prescription at destined places all over. She has already mentioned all the institutes have, even Savira has, Medanta has, almost all of them have. So with a prescription, but it should not be freely available.
also the psychologist is the most important part, the psychiatrists are there, we have the dietitians and everybody who is taking care of this department. So we are just having an introduction to this part, and we are soon starting up in palliative care in our center too, and we will having all these things with the whole team, not a single person.
Palliative care per se, as we just started, so that's
Yeah, thanks
Hello.
to all the chairpersons.
1 minute. As well said by Dr. Arvind, age is just a number. So you should know the difference between the chronological age and biological age.
Right.
Suppose one of the patient 65 plus and as fit as Barack Obama, and another patient with multiple comorbidities, then we have to consider if the patient performance status is good and all the organ functions are normal, organ reserves are normal, we can treat with the standard protocol.
Right.
And definitely if the patient has multiple comorbidities, we can go with the like metronomic chemotherapy, one of the option, another targeted therapy and immunotherapy. So we have multiple options. Thank you.
Thanks for the input. Thanks to all the chairpersons. I am personally obliged to all of you because you took time out of your busy schedule and you are here. Thanks. And thanks to the audience for the patient hearing. Thanks a lot.
I'm Dr. Verma, I'm a postgraduate diploma in yoga also. Apart from being a general surgeon, assistant professor in surgery at NMCH. Is there any role of pinealocytes? Is there any role of pineal gland and pinealocytes in the process of aging?
I am not sure, sir. I will have to go back to the book and then I will have to read. As far as pineal gland is concerned, yes, it has a role in sleep.
Sleep and wake.
Whether it has, the second part of the question I missed, and I think it. I will have to go back to read.
We have to learn about that.
Yeah.
Yoga is a different science, the science of prana, the flow of energy into its channels to each and every organ.
So, from Tata Memorial at a phase 3 trial in breast cancer, and which was presented at Barcelona, and it said that it had positive results on overall survival as well as symptoms, breast cancer, the symptoms of breast cancer patients. And this was such an important trial that it found a mention in Pradhan Mantri's Man Ki Baat. So yes, yoga has role, but before that we had holistic, I had read it in my book that there is a holistic and integrative medicine at Memorial Sloan Kettering Cancer Center where they do trials on yoga, and it was done well before Tata Memorial did the trial. So that is very important that it is our thing and they are doing.
That's all within ourselves. Brahmari Pranayam releases so many good neurotransmitters. Why don't we utilize those for pain relief?
Yeah, that can be done.
Endorphins.
Yeah. We have to collaborate for that. We have to collaborate for that. Thank you.
We'll have the Pradhan Mantri very fully talking about the yoga programs and the Man Ki Baat. Let's go ahead. Can I request Dr. Sanyal to felicitate our chairperson for this speaker? Dr. Sanyal, the chairman, he's the managing director, Mavi Cancer Center. So, can we have you this week? It's such a pleasure to have you, so we'll be chairing the session as well. Yes, yes. Can we do away with the felicitations? Yes, yeah. Okay. So, Dr. Arvind Kumar. One of the audience members Dr. Avinash. desiccated it. Humility and integrity.
Thank you very much for calling me here.
Our pleasure.
Over to the next session.
Can I have the privilege of inviting Dr. Deepak Singh? His appearance speaks for itself. So are you 20 years or 30 years of age? Okay. So Dr. Deepak Singh specializing in head-and-neck oncology surgery, reconstructive surgery and skull surgery, and having an experience as University of Miami. Dr. Singh also brings around an experience of more than 20 years in the field, challenged society and local society of the body as well. He's been instrumental in developing the head and neck cancer department and is trained as a clinical fellow in head and neck ablative as well as surgery at the Centers of Comprehensive Cancer Center, University of Miami, United States. His expertise lies in organ cancer, throat cancer, thyroid surgery, including robotic surgery, parathyroid surgery, including minimal invasive techniques, colorectal surgery, treated reconstruction, and laser and robotic for head and neck cancer. He's keenly involved in the clinical and translational research and has a passion for education. He's also been instrumental, in fact, he's established the Department of Head and Neck Surgery at Surgical Hospital in the year 2005. He's also been instrumental in establishing the Department of Head and Neck Surgery at Artemis Institute in the year 2007, and he's also established the Department of Head and Neck Surgery at MEDANTA in 2011. Can I have the chair? Can I have the chairpersons as well? Starting with Dr. V.P. Singh. Dr. V.P. Singh, sir, please. Dr. V.P. Singh, heading the cancer, the severe cancer system here in Patna. Dr. Rachel Manpuri Khan. Is she there? Okay, I've made it. It's Dr. Vinita Trivedi, ma'am. A dynamic leader, as well as serving as the head of the department, Radiation Oncology, Mahavi Cancer Center. Can we have a big round of applause for Mahavi? And Dr. Dinesh Kumar Sinha, Radiation Oncologist, Indira Gandhi Institute of Medical Sciences. Without further ado, it's over to you.
Thank you. Thank you for a very kind introduction. Just with one correction, you said I'm 20 or 30. I'm probably more than the sum of those two. But I'll start with thanking the other speakers in the session who allowed me to speak before them because of the flight that I have to take. And I'm grateful for that privilege that you've given me. In head and neck, when we say what do we treat, we can summarize our field as ENT oncology. The majority of work that we do is treating upper aerodigestive tract cancers in the mouth, in the throat, in the larynx. We treat diseases of the thyroid and parathyroid glands and also tumors of the salivary gland system. We do a lot more than this with tumors of nose, paranasal sinuses, ear, temporal bone, skull base, benign diseases of the neck, etc. Sort of summarized from dura to pleura. But today, what I'll do to introduce my field to many of you who may not be familiar is focus on 5 anecdotal developments that we've seen in site surgeries in our field, using both surgical expertise advancement and incorporating new technology into it. A vast proportion of our patients are mouth cancer, and I'm sure we're all aware that India is literally the mouth cancer capital of the world, with 50% of mouth cancer patients being Indians. Some present early, but unfortunately in our country, many come with advanced disease. And we've all heard or known somebody who's undergone debilitating mouth cancer surgery. When they present with advanced diseases involving the mandible, typically the operation would involve resecting the jaw. And we would reconstruct it with soft tissue from the chest. But unfortunately, that would leave them with mandibular discontinuity. And with this came a lot of handicap. There was obvious aesthetic changes on the face. You would have functional impairment with inability to chew well, and significant change in voice. And many of these patients would live their life as social recluses because of that. A lot has changed in the last couple of decades with the introduction of microvascular free flap surgery. So what we can do now is take vascularized bone from the leg, the fibula bone, with an artery and vein, transpose it into the defect of the jaw to re-establish the mandible continuity, anastomose the artery and vein to branches of the external carotid artery and internal jugular vein to re-establish blood supply, and reconstruct the jaw. Sometimes the entire jaw can be reconstructed. It's really changed the quality of life of patients undergoing surgery for mouth cancer. What I'll highlight today is a refinement that we have been trying to develop and establish over the last 6 years, which is if I'm audible, I'll continue. Sure. So what we've developed in the last 6 years is using virtual surgery or CAD/CAM based planning, which is a software based planning, to not only design the resection of the jaw that will be done, but actually design the shape of the fibula bone which will be used to reconstruct the jaw. And the idea is that what we remove and what we replace it with should be almost identical. How long would the slides take to come on? How long will it take to come on? Ajay? Okay. And I'll just run you through what this 3D CAD/CAM based and 3D printing involves through a 1-minute video, but I would need projection. Yeah, we have it. So what you do with this is you take the DICOM images of the CT of the patient, put it in a software, and that allows you to reconstruct not only the mandible of the patient, but also the fibula bone of the leg. We would then perform just the video is hung. So once you've got the images in your software, you would then perform virtual surgery on the software. You would resect the portion of the jaw that you want to remove, and you would then design your fibula graft in a shape that would closely mimic the resected segment of the mandible. Sorry, I think we have a little bit of an outage. Can somebody help? I think the power going and coming has hung the system. Let's go. Got it? It's not closing. लाइट जाने से हैंग हो गया. दूसरा लैपटॉप है. I'm very sorry. I think the power outage caused the system to hang. HDMI. Thank you very much for your patience. I know this is very frustrating, but thank you very much. So, what I was talking about was how we use the CAD-CAM based surgical planning to first decide what we're going to resect in the mandible. We can also account for dental implants if we want to rehabilitate the teeth as well. And then osteotomize the fibula, which is a straight bone, to give it the angulations, shapes and contours that we need to reconstruct the mandible. Then we 3D print guides that will help us recreate this operation in the operating room that was done on the software. That's the guide being fixed on the mandible. That helps with the mandible resection as planned. And that's the guides that will go onto the fibula bone that will help us osteotomize it in a manner that when we bring the segments together, we will now be able to recreate the contour of the mandible segment that has been excised. So it's sort of a like fit for a like resection. And this segment is then brought into the mandibular defect and the entire mandible contour is restored. Couple of images. You could also place primary dental implants if you wish to give teeth in this jaw. And these are a couple of pre-op and post-op images showing that the results are aesthetically very good. And also functionally very good, because you can restore teeth in many of these patients so that they can go back to enjoying a life that they used to have before undergoing treatment for mandible cancer. Moving further back to tumors that arise in the throat, one of the initial issues with treating these was access. So in the 80s and 90s, when we used to operate on these patients, you had to dismantle the facial skeleton to reach the tumor. In this case, you see the images, we are opening up the mandible so we can get into the throat, where we'll perform the operation and then try to replace the mandible back in its position. But an operation that obviously had a lot of functional morbidity with it, and which is why radiation kind of became the standard of care for tumors that arise in the throat. But the wheel's turning again, and that's with the introduction of the robot that now allows us to reach the throat through a natural orifice, which is the mouth. We can place a camera that gets into the throat so we can visualize the tumor, and we can introduce instruments that are wristed and can be moved around to help resect the tumor. In this video, we have a patient's mouth. You can see it's a right tonsil cancer that we are removing. So that's the cancer, the small, you get glimpses of the cancer there. That's the uvula. You can see the uvula hanging, and that's the tonsil, and that's a cancer that we are resecting using robotic instruments. The camera is actually three-dimensional, so you get an excellent image that is a 3D image, which of course doesn't reflect in a video, and the instruments are wristed like your hand with 7 degrees of motion. So you can get around corners and you can resect these tumors out with adequate margins, with no facial incision, no disturbance of the normal functional anatomy of the mouth, and these patients recover with excellent swallowing function. We were very fortunate last Thursday, just 3 days ago, to actually perform the first transoral robotic resection with an Indian-made robotic system, the SSI Mantra, and we're excited to be able to participate in the development of the instrumentation, because this is a system that's about a third of the cost of the market leader. So the penetration of the robotic system hopefully can be deeper because cost is very prohibitive otherwise. Patients with the glottic or vocal cord cancer often present very early with small tumors because there is immediate onset of hoarseness the moment the growth develops. Interestingly, because the glottis is very sparse in lymphatics, they also don't develop nodal metastases early. Radiation is an excellent way to treat these patients with very, very high cure rates. But what I'll demonstrate is the alternate option of doing a laser resection for tumors that are small like this. It's a small tumor on the left vocal cord that we are assessing telescopically for its extent. And in the next video, I'll show how we can resect these using a carbon dioxide laser, which does have some advantages. So the tumor is exposed with a laryngoscope in the operating room, and a microscope is hooked up to visualize it with magnification. The carbon dioxide laser is attached to the microscope, and it's a fine cutting beam of the CO2 laser that allows you to cut very precisely with very little charring and burning of surrounding tissue. With early glottic cancer, you can resect with very, very small margins. You only need about 2 millimeters of normal tissue around the cancer to take it out. The red spot is where the laser beam will cut. And initially this is the mucosa that is being inside, so I am marking where my resection will go. And subsequently with the carbon dioxide, we'll resect this entire specimen out and send it for pathology. The advantage of a carbon dioxide laser resection for early glottic cancer is that it's a quick operation. It's about 30 minutes it takes to do the surgery. The patient stays overnight and then can go back home and resume his normal life. This, I think, is a big advantage for patients who come from out of station, where staying for long courses of radiation sometimes is practically or logistically a little difficult. And in suitable cases, a laser resection is an excellent alternative for patients who come with early glottic cancer. That's the entire cancer being taken out. And that wound in the vocal cord will heal in about 6 weeks with restoration of normal voice. Moving into the neck, a classical open thyroidectomy is normally, it's a very well done, precise surgery with very low complication rate. But occasionally you can get poor healing. On the pictures you can see some good scars on the left vertical, and on the right vertical there are some poor scars with hypertrophy and keloid, which is just a patient driven factor. Sometimes you can't do much about it, but it can leave a very unsightly scar in a very visible area of the patient's body. And for many patients also, carrying a scar of any kind also is a matter of medical privacy. When people see a scar, they'll often ask, kya hua, kya tha, and one may not want to discuss your medical history with people whom you're not close to. So there are some patients who really want to avoid a scar on the neck. For them, we can perform a thyroidectomy through remote access, again using the robot. And this is done with an incision that's put behind the ear in the hairline, and when it heals, the scar is hidden in the patient's hairline. The robotic instruments are then introduced through this incision and tunneled down towards where the thyroid is, and then again using 3D vision and robotic grasping instruments, cutting instruments and coagulating instruments, you can perform a resection and take the thyroid out in what one would call scarless, but really it's truly a hidden scar, not really a scarless operation. That's the recurrent laryngeal nerve, which is very, very important to save in a thyroidectomy being identified. And the operation can be done with equal safety as an open surgery. What's also helped is the fact that we now have intraoperative nerve monitoring available. And that's a tool that can measure EMG signals on the vocal cords, and you can check the integrity of your recurrent laryngeal nerve functionally. So you can not only preserve it anatomically, but ensure that it's functioning as you're doing the thyroidectomy and enhancing the safety of the surgery. The last site I'll touch upon is something that's actually a little removed from cancers and tumors. And it's something that many specialties see, and that's primary hyperparathyroidism. I think Dr. Rajiva Gupta almost mentioned it in his talk when he said bone pains, back pains, joint pains, non-specific, do calcium, do PTH. And that's because sometimes this is a symptom of primary hyperparathyroidism or overfunctioning of the parathyroid glands in the neck. Easy to diagnose. Biochemically, they'll generally have increased calcium, increased PTH levels, and normal creatinine. We'll remember from MBBS, there used to be this euphemism about this disease: bones, moans, stones, groans, psychic overtones, and kidney stones and skeletal manifestations. Osteoporosis are among the dominant clinical presentations of this disease. But what we are seeing nowadays is that many of these patients are now presenting with very subtle symptoms. In fact, fatigue and vague aches and pains is the most dominant presentation now. at least depending on where you work and what segment of the population you drain, we're seeing lesser of kidney failure, huge kidney stones, recurrent kidney stones, pathological fractures. But we are seeing more presentations like this, and this often gets overlooked because this actually matches aging. The disease is common in 40, 50, 60 years of age, and when you have these symptoms, it's very easy to think of it as aging or just work stress. That's why I'm tired, or that's why I hurt, or that's why I ache. And a lot of these patients don't get the diagnosis for a couple of years, even though they have the symptoms. The classical operation was you put a wide incision on the neck, you went around and hunted for the 4 parathyroid glands. Once you found them, you removed the one which was abnormally large, presumably had an adenoma. Most of the times the disease is caused by a single adenoma in one gland and other 3 are normal. So today with localizing studies, what we can do is we can find which is the abnormal parathyroid preoperatively and then use a small focused approach with a minimal incision to take that particular adenoma out and not disturb the other normal glands. So this is a video showing what we do in a focused approach parathyroidectomy. This is a sesame B scan and ultrasound images which showed that we had a left inferior parathyroid adenoma. So it's the left inferior parathyroid which is harboring the tumor. Once we know where the tumor is, we can place a small incision that's about an inch over that area. For this video, I'm actually going to be introducing a camera so that you can visualize it better. And then the approach is very similar to how you approach a thyroid surgery. You look for the parathyroid, generally it's fairly easy to find. The only care we have to take in parathyroid surgery is that parathyroids are very friable. If you grasp them too hard, you will burst them. And if you burst them, then you will implant the adenoma cells in the neck and they will have recurrence of disease, and that's almost impossible to cure because it's wide field seeding of the adenoma cells. So you just have to be gentle when you handle these glands. And that's the adenoma that has now been localized. It's been resected, enucleated, and we'll take it out and send it to pathology. And those are structures including the recurrent laryngeal nerve which can be visualized. So this surgery being minimally invasive generally requires overnight stay in the hospital, and you do land up with very, very good aesthetically pleasing or almost invisible scars. I'll summarize by highlighting one of the pleasures at working of Medanta is the ability to deliver multidisciplinary care. So we have a very strong parathyroid program. We've operated over 500 patients now over the last 10 years, but this program is driven on the back of many specialties. It's the endocrine team that drives it, and we have excellent support from radiology, nuclear medicine, pathology and biochemistry. And that's allowed us to expand the program to its current levels, and I think that's one of the pleasures to work as part of a team. And with that, I acknowledge all the people whom I work with and who help us take care of these patients. Thank you very much.
Dr. Sareen, really a very good presentation and a very comprehensive, short, crisp. The message was well, I think, delivered in the audience. And just a couple of comments. Basically, this technique of mandibular resection, CT-based planning, this is a very good technique, and practically we have also been doing this. As long as the vocal cord is concerned, we have been doing laser vocal cord ever since 2001 only. And I think many of our colleagues are practicing vocal cord laser surgeries in Patna as well. But the thyroid, are you practicing malignant disease also with the robotic surgery for thyroid, or only the benign one? For the thyroid surgery?
I do only benign.
Only.
We have a very high threshold to offer it because I think the aesthetic scar on the neck is actually really good. So it has to be a very demanding patient to whom we'll offer robotic. Generally for benign nodules, although it's been used for small cancers extensively around the world with excellent results. but we have a fairly high threshold whom we will offer it to.
Yeah. The one approach you told is the post-auricular approach. The other one, people have tried the axillary approach as well.
Yeah.
So which one do you think is better?
I like the retroauricular because, I mean, you could use either. So it depends on what you develop as an expertise. So there's the axillary approach, there's the below the breast approach, these are the infraclavicular, and then there's the retroauricular. And there are different champions for each approach.
Okay.
I like the retroauricular because if you have to dissect the neck per se for a case with cancer, you can actually do it through the retroauricular approach.
Yeah,
so if you have to extend the operation, it's fairly easy to do it. And but there is nothing to say A is better than B. It's really what you're good at is good enough. This is one of those situations.
And for bilaterally, you have to go to the opposite side
you
as well.
You can actually do it from the same
side.
But often you will have to give bilateral, but you can do it from the same. It's about how good you are.
Yeah.
So
and
the experts will actually do with one side, they'll manage to take the whole thyroid gland out.
Great.
I can't do that.
Okay. And the robotic, you told you are using Mantra. Mantra has come up very well in the last 1 or 2 years, I suppose.
No, we've done one case.
One case.
3 days ago. But it's the first time Mantra has been used for a head and neck resection. Okay. It's been used in urology and many other fields, and I think there are 8 machines already established in the country.
Yeah.
But what I highlighted was that we did the first transoral robotic resection using an Indian-made system. So it's something for Indians to be proud of.
What we have heard that the instrumentation is a problem with the Indian setup, because Da Vinci has got more instrumentations which we lack in Mantra.
So Da Vinci has 2 decades of head start on Mantra. But I'll tell you about Mantra. Their R&D and development center is in Gurgaon. So we went and trained there. We told them what because they were not familiar with head neck. We told them what our requirements are. They have an in-house 3D printer. They printed and gave us the instruments to our requirement. That's very difficult to do with the market leader because they have a lot of monopoly otherwise. So they are a company that listens. They are willing to innovate. I find that very good. It's not as fine as as the market leader, but I think if they continue to listen to feedback and develop, they will get there. 80% of components are made in India. So it's very easy for them to innovate. They're not dependent on somebody else for at least the mechanical instrumentation mechanical components are all Indian.
Yeah, true.
So they can innovate and develop as whatever feedback we give them.
Yeah. Thank you.
So congratulations for your brilliant presentation. So being a radiation oncologist, I just want to emphasize that minimal invasive surgery is a very, very good technique as far as to deal with early malignancy. Especially there is an increasing evidence of using TORS, that is transoral robotic surgery, especially for the oropharyngeal cancers, especially for T1 and T2 disease. But proper selection is very, very important for the patient, because in a lot of trials we have seen that after going for TORS, majority of the patient, they require adjuvant radiation. So the basic purpose of doing minimal invasive surgery as far as cosmesis and to limit the side effect of radiotherapy, so that is defeated. So the proper selection of the patient is very, very important before you take any patient for minimal invasive surgery. Means the patient should not require adjuvant radiation or radiochemotherapy. So this is the point which needs to be highlighted. And yes, as far as laryngeal cancer, we are doing laser surgery for very, very early disease, a small solitary lesion in that vocal cord. And you rightly told, and T1, T2 disease, usually the lymph node metastasis is almost remote. The chances is less than 1%. So we can go for these minimal invasive surgery. But proper selection is very, very important, as well as because the main purpose of minimal invasive surgery is to achieve cosmesis as well as functional outcome and overall the survival. So we should not compromise on the functional as well as the survival outcome of the patient. And so the proper selection of the patient is very, very important. This is as far as oncology management is considered. Thank you so much.
Thank you very much, sir, for making the patient's quality of life better by minimal access. So, I can precisely say that maximal gate maximal access with minimal gate. So, as a radiation oncologist, as a rule of thumb, if you cut the line from by coronal line through uvula, the anterior from anterior to that line, we send the patient for surgery first, and behind that, like nasopharynx, oropharynx, base of tongue and larynx, we usually go for definitive chemoradiation. But with Serene sir's minimal access, I think we can do in these cases also a better treatment. So thank you very much, sir.
So do you have any experience of HPV positive oropharyngeal cancer? Because these patients, they will be doing very well because the overall prognosis is good. But the thing is that they present with a big primary disease, these HPV positive, and they are young patients. So what do you have to say on this?
Yeah, ma'am. I think Dr. Sharma had also alluded to the HPV in her talk and about the vaccination, and there was a comment that men should get it too to prevent oropharyngeal cancer. So it's an epidemic in the West. It's an epidemic. For most head and neck surgeons, 50% of their practice is now dealing with HPV related oropharyngeal cancer. And as you correctly pointed, they do present with large lesions, but generally they are proliferative. They don't have a deep invasive component. And the majority use of TORS or the robotic resection transorally is actually in the HPV positive segment. We see patients here. We routinely test all pharyngeal cancers now for HPV. The percentage of pharyngeal cancers which are HPV positive in our center is about 22%, but in the West it's almost 90%. So the smoking related cancer is going and the HPV related cancer is coming. Interestingly, as you said, they do very well with radiation. They are highly radiosensitive cancers, but they also do very well with surgery. The results with surgery are equally good. So these cancers do very well. And like you said, these are people in 30s and 40s. So they're going to live another 40 years. They're going to develop second cancers, third cancers. They have 40 years of life. So TORS is really good in this segment when appropriate, because you can save radiation for the really bad cancer that a TORS can't handle. And that way you safeguard an option for them for the next cancer they get or the third cancer they may get in their lifetime, because they are young people.
Thank you so much.
Congratulations for showing the very good cosmetic reconstruction of the mandibular tumor. One question is that you have dissected the donor, the tibia bone, into pieces. When you do that, are you compromised with the vascular supply?
Right. No, sir. You have to take care. So we take the fibula. You take the fibula out intact. But it's a straight bone, so to give it angulations, you have to osteotomize it. But the periosteum is kept intact, and the supply is through the so each of those segments is anchored on the periosteum, and that's where the supply comes from.
So maintain the periosteal continuity.
Yes. Otherwise, they would likely die, or certainly when these patients get radiation, that bone would get extruded.
Right. Second point, there is the option of rib reconstruction also, rib.
Yes.
Do you prefer fibula or the rib?
So the rib used to be used with the pectoralis flap. So when we used to do the commandos, surgeons would do the rib as well. But the rib doesn't have the strength that the fibula has. So, and you can't contour it. You'll get the shape that you get, but you can't contour it to the patient's mandible shape. So pretty much today, also the rib had huge issues with resorption. Over time, there was a high level of resorption of the rib bone. So I think today, if you want to put bone, then you need vascularized bone, and fibula is the workhorse pretty much the world over now.
The third point is that if we use the prosthesis, you have a three-dimensional configuration, make a prosthesis, put the artificial tooth, put it there, that will be much easier.
Yeah, we've done it, sir. But the issue is you can only do it for benign disease. So we have 3D printed patients' maxillas, 3D printed calvarial skull. We have 3D printed, actually printed the implant that will go in. With the mucormycosis that we all saw with COVID, many people lost their maxillas. So we've done full jaw reconstructions with the 3D printed implant. That's an implant being placed.
Yeah.
But you can't use it for cancer, because if you radiate on that implant, it will get extruded. You need vascularized natural tissue to withstand radiation. So for benign disease, we have.
Thank you very much.
In fact, to add up to this, sir, in fact, way back in, I would put it as 95, 96, people were using celastic implants for reconstruction of the mandible, and even the osteomyocutaneous flap from the pectoralis major. But pectoralis major has, the osteomyocutaneous has got a lot of morbidity over the chest wall. So that was the main reason why it is abandoned. And celastic, as you rightly pointed, it gets protruded once radiation happens. So fibula is the only answer.
I think,
Thank you very much.
Can we conclude the session?
Sorry. Yeah, it's that's right. Give a surgeon an orifice and he'll put a scope through it. We are waiting for the transrectal report to come out. But yeah, so transoral thyroidectomy has been described. In fact, some centers are pioneering it, and that they say is truly scarless because there is no scar visible at all. I haven't warmed up to it. Of course, it requires expertise to be developed, but also because there is stretch. When you go transorally, you basically incise under the lip and then tunnel under the neck skin to the thyroid to resect it. There is a lot of stretch on the mental nerve. And there have been many reports of the mental nerve being avulsed and then hypoesthesia on the lip, which is very distressing because you can't feel food here. And if you're dribbling, you won't know you're dribbling. It's completely. So, given that an open thyroidectomy, conventional, is so safe and so good, and such a well-established operation, it's very difficult to move to a remote access where you think you may add some morbidity to the patient. So I haven't warmed up to it, but there are centers that are doing it, and there are surgeons who are adopting it, and maybe in time there will be a place for it going forward.
Can we close the house, or do we have any questions? Okay, great. Sir, Dr. Jitendra Kumar Singh, can I have the honor of inviting you, an ex-Padma Shri awardee, an ex-director, Mahavir Cancer Sansthan, and currently heading the SS group. Sir, can we start with the felicitation? Dr. VP Singh, sir, please. Dr. Dinesh Kumar Singh. Dr. Vinita ma'am. For Dr. Deepak Sareen for taking the pain of coming all the way from Delhi to Patna. A big round of applause. Sir, please. Thank you so much, sir. Thank you so much. Ladies and gentlemen, we understand we are running late. Proposed lunch would have happened at about 1:30. This is for the audience. Should we continue with the sessions, or should we, take a break for lunch? Continue kar lete. Perfectly fine, sir. Can we have a next session? I'd like to invite on stage Dr. Rajiv Ranjan Prasad. Sir, Dr. Rajiv Ranjan Prasad on the stage, please. Sir is going to he's going to speak on cancer care, present and future. And can I have the chairpersons? Dr. Jitendra, sir, you'll have to chair this session as well. And Dr. Seema Devi as well. And Dr. Sujit, who's also an additional professor, hospital management, and the deputy MS in AIMS Patna. Without much ado, let's make a start.
A very good afternoon to all of you. This conference has something very unique. You know, we have so many Rajivs speaking today on the session, and so anyway, I'm going to speak very less because everybody is talking about cancer. And the reason why everybody is talking about cancer is that very soon we are going to have a phenomenal number of new cancer cases all over the world, and largest increase will come from Asia. If you see here, largest increase will come from here, and if you see our neighboring countries, China, India, Bangladesh, Pakistan, all of them will have very, very large number of cancer cases. And why it is important, or why we have to plan, because 70% of these cases will happen in low and middle income country. 80% mortality will happen in low and middle income country, and where the resources, only 5% of resources to deal with cancer is available. So we have to plan. Another thing which is very important to understand is that we will have a very, very large number of cancer survivors. Because the treatment is improving, patients are living longer, and we do not have enough oncologists. So here comes the role of physicians, surgeons, and everyone. This is also true for pediatric patient, which is a unique group, where you will see the survival upwards of 80%, 90% in Western country, though it is not as good as in India because of lack of facilities, but they are going to survive, and we need pediatrician to chip in to help those patients, because follow-up is very important and early diagnosis is very important, so everybody is required there. Look at the escalating cost of health facilities. That's the figure from US. Huge increase in the cost of cancer care. And if you look, there are other things which add to the cost of cancer is indirect costs for transportation, housing, etc. So these things are going to increase. So when you are fighting a bigger enemy, you have to plan well. Large number of cancer patients lose their mother, and they are orphaned because they have lost their mother because of cancer. So it's a huge number, and it is maximum in Asia. So that's why I have put it. So there is a social effect as well. Prevention, very easy to say, but very difficult to bring it in practical. Still about 30% of our cancer patients are because of infection. For a very good example is carcinoma cervix, and this will continue for a long time despite our best efforts. So tobacco is a major killer. 80% of 1 billion smokers of the world live in low and middle income country, and China has the highest smoking rate in this part of the world, closely followed by India. So we need to do a lot on this pollution. I put this slide I put this slide here because pollution is going to be a major cause of cancer in coming years. Then if you look, this is a hunger data. Large number of patients cannot afford a good quality of food. But you will be surprised, overweight kills more people than underweight. So obesity is going to be a problem, and we need to tackle that. And why? Because many cancers are obesity linked. And one of the commonest cancers that we see here is endometrium. And it has one of the strongest link with obesity. Other cancers are breast cancer, ovarian, colon, lung cancer, and prostate also. lot of developments have happened in the field of diagnostics, and these will grow. I put a question mark purposely because many more things will be added. And look how we are classifying based on these molecular markers. So things are changing, and it will continue to dominate the field of cancer. This is one thing, how we categorize a patient into a high risk or a low risk group. And if by doing this type of test, you can totally avoid chemotherapy in certain group of patients. The other thing is that it is also possible, it will be also possible in future to do genomic testings and avoid radiation also. It's already there in Switzerland. They have piloting it. Maybe in coming years we will have that in India as well. I'm sure when Dr. Sanyal was a resident, he must have seen lung cancer as one disease. Then when we were resident, it was squamous and adenocarcinoma. Later on, the adeno, you see today, the adeno itself has so many varieties. So things are changing. This is time to adopt all these things. Endometrium, we only knew endometrioid carcinoma, clear cell, serous variety, and see how it has changed. The other thing is medulloblastoma. It's totally classified based on the genomics. So the treatment is based on these things. Now, it has already been discussed, combined modality treatment. I'll just skip in the interest of time. More and more combined modality imaging will be used for therapeutic purposes. Like, you know, the amino acid PET, these things are going to be used for radiation planning. And there are evidences which suggest that you can plan much better than simply doing a PET scan or MRI or CT scan. In the recent year, what has happened is that we can even spare hippocampus, cochlea, all these things were not possible, and this is happening. So you can spare because if you treat a brain tumor patients, you know, cognition was a problem, especially the ALL patient, but we have the tools and we can spare all these things. Radiotherapy is a very important branch. 50 to 60% of cancer cases need radiotherapy. And you re-irradiate also in 20-25% patients. Either it can be used alone or in combination. Multi-step process requires teamwork and it is cost effective. But I have put it purposely that if you move from cobalt upwards, the cost increases, the human resource requirement increases, and also the maintenance cost also increases. So it's not just bringing the technology. You have to have right kind of support to support that technology. The man behind machine is also very important. This is the primitive machine of radiotherapy, and you see this is carbon ion facility in Chiba. You see the back of the machine, how huge it is. So all these things require training, expertise, and you have to choose the right tool, and it is very important that you have the right tool in your hand. So choosing tool is also important. It should be in the right context. Now, radiotherapy will continue to grow. Now we have SBRT, SRT, IMRT, and so many things, proton, carbon ion. We have moved from 2D to these techniques. And why we are talking about proton and carbon ion is because of this effect. You see, if you use photon, the dose goes beyond the tumor. But if you are using proton, it is precisely there, and the dose beyond that is very less. But as of today, we do not know whether it will increase the survival or not. Of course, it is expected that toxicities will grow. will be reduced. And all these things have happened because of the computerization, better imaging, and artificial intelligence. Just a line about flash radiotherapy. You know, is one kind of treatment which is emerging. Here you give a very high dose and you finish the treatment in milliseconds. Like 40 gray you give in milliseconds. So, you know, if that happens, what will happen? You don't have to stay. The treatment is shortened to milliseconds. Like normally we give radiation over a week's over 7 weeks or 6 weeks or so. You can give it in milliseconds. It is possible. And first patient has been treated. There are reports, but it is in developmental stage. So perhaps in future we are going to have this type of things. Radiotherapy is one branch where artificial intelligence is going to play. In fact, it is one of the first departments where artificial intelligence was used, and it will continue to dominate our field. Radiotherapy is not a single, it's a multi-step process. You start from here and then go up to here. It's a multi-step process, and every step artificial intelligence is going to help us. We had traditional modalities, surgery, radiotherapy, chemotherapy. Now, huge armamentarium has been added in the form of immunotherapy. And what will happen? We will have a combination of these medicines. So, future is of combination, not a single modality. The fight against cancer is a long road ahead, and we will have to do research, but research in low and middle income countries, our own problem we have to solve, and we will have to do the research for ourselves. The telemedicine will dominate the field. We have learned a lot with COVID. Last and the most important thing is, no matter what we do, everything should be available to the lowest society of a strata of the society. Thank you very much for your patient listening. Thank you very much.
Thank you, Dr. Rajiv, for your excellent presentation. You will agree with me that the last few decades, there has been tremendous advancement in the field of oncology, as you have already enumerated in many of your slides. Whether it is surgical oncology, medical oncology, or radiation oncology, all have tremendous advancement. But in spite of the advancement in those fields, the outcome, I mean the incidence is always the same, the mortality is always the same. It's not very differ with this technological advancement. We are passing through a technological explosion area, we can say it. But even in spite of that, mortality rate is the same, and the other things also same. Because India is a poor country. Many things we don't observe, don't give focus, don't give concentration to those areas which are really needed in this country. Cancer is a long disease. It's a costly disease also. Cost-wise also, it's very high. What we want to say, and I'm a firm believer, that we have to develop in our country the community oncology area. We have to give more focus, more concentration on these areas. If you don't aware the public, if you don't educate the public, if you don't go on prevention, if you don't go on early detection, probably we'll remain whatever we are in the next few years also. So if you want to change the things, we have to focus on these areas. Research, it's also our research, our data, we should produce it. So I'm sure every people here will agree with me that This is one area we are not focusing right now. We are not giving treatment. It's okay. Treatment advancement is very good. Make the impact of the treatment on the cancer. But why not we should develop these areas also, which is not being given adequate concentration in the country. Thank you so much.
Can I request Dr. Nandha Singh to kindly come up and facilitate our chairperson's speakers? Please. Can I request Dr. Kumar Singh, sir? Can you certainly facilitate? So you can start to use your people at the behind the back, please come in the front. Please. Come, please. Yeah. This has got nothing to do with this, you just really, you're preparing for this course, you're preparing for this course. Ma'am, please. Dr. Jitendra is photos will be, it's not a big time of circle this thing. We'll be handing over this. Sir. We have it. Few blessings, but then with your blessings, I think we'll save it. Dr. Sujit, the next Dr. Sujit, and he's helping the bouquets, the photographs will ensue. And finally, Dr. Ravi will do this. I'm requesting you to recheck the session. Please. Please.
तो उसका नाम था गलती से छूट गया।
I'm actually using this time. I want to thank the organizers for giving me this opportunity to be present here in such an august gathering and with so many illuminating talks that I have been listening since morning. And since a multidisciplinary sort of meeting, I think They have selected very good topics, and many of the topics just motivated us so much and sensitized, especially about Dr. Amarendra's talk. That was very good, sensitizing all the doctors towards palliative care, especially taking care of the older people. So thank you very much for calling me here to chair this session, and I am very much proud to say that Dr. Amit is one of my favorite students from Patna Medical College, and this is a great opportunity for me to chair the session, which is going to be the talk which is going to be delivered by one of my favorite students, Dr. Amit.
Can I have on stage Dr. Sanjeev? Can I have Dr. Sanjeev to kindly come up and chair the session? So Dr. Sanjeev, sit please. So please. Dr. Anita Singh. I'm so sorry, I apologize. I could listen to Dr. Ravi Gehroot, please. Dr. C. Khandelwal, Dr. Khandelwal, sir, please. Dr. Avinash Upadhyay. Should we start? Yes.
So, very good afternoon to all, and I will be very crisp, I think so, but the topic is not like that, and it is the next future of cancer, how, and basically I will say it's the present scenario, what we are doing in the cancer at present. The things have now moved on from the simple chemotherapy zone or radiotherapy zone to a precision cancer care. And what is this precision care? As we know that it is now, we are not going as a group for as a cancer, it is about the individuality of a person and basically the individuality of a tumor, how we deals with. So anything which affects the genes, its behaviors such as your exercise, eating habits, the environmentals in which you are living, all these things are affecting your health, and these are called the precision health. And that has to be modulated for them to, and the intervention has to be done based on that, so that it can give the betterment of your health. So this precision health approach can better predict what disease you are going to get, how to prevent those diseases, and how to treat and manage these diseases in these cases. So this is for any cancer, the most important thing is how you are going to solve that. So you cannot cure until you understand what kind of a cancer a patient is having and how you are going to treat that and what is the cause for that. So for every person, I will say he's a unique individual, and so every cancer. So we just say a word cancer, it doesn't mean it is a uniform thing, or even a particular cancer is also not a uniform thing. So every cancer is an individual and a different thing. We have got these hallmarks of cancer which have been developed and which is the most important thing, and there are many things that evades our immune system, and there is a sustained proliferative growth which occurs, we say, and that growth causes the growth suppresses, in which our body which suppresses the growth is not functioning. So all these things comes in picture and it leads to the growth of cancer. And after seeing all these things, the many medicines have come out and targeting all these different approaches in cancer. So there comes the role of personalized medicine, and this is given different names and there are different definitions from different institutes for this, whether you are calling it as a personalized genomics, genomic medicine, precision medicine. Basically it all deals with the patient specific profile, their genetic data, the genomic data, and the environmental factors. So any patient personal medical history, family history, his physiological status, and the molecular characteristics of the tumor. All these things take care of how does the patient is going to behave. So the NCI, the National Cancer Institute of US, it simply says the targeted therapy is now the norm. So we are not treating every patient with now chemotherapy, and we know that chemotherapy has got a soul, that it works for a short period of time and then suddenly the patient starts progressing on them. So there we are now finding out what target we are going to hit exactly, and how does that is not affecting the normal tissue and is affecting only the cancer tissues, and we can control the disease. So these targeted cancer therapies basically interface with those specific molecular targets, we say, which is causing the growth progression of the disease in this group of patients. And it is somehow different from the conventional chemotherapy, as we say that conventional chemotherapy is simply acts on all the rapidly dividing cells, whether they are cancerous or the normal cells. So there is a basic mechanism of action, and they are mostly cytotoxic. But for the targeted therapies, the cause of the cancer, what is the specific molecular target which has affected that, it is going to hit that only, and this is the norm which is now going to be followed in most of the cancer, and we are searching for these targets in most cases. So even in the last ESMOs, it has also been discussed that there is a personality medicine is a result of last 20 to 30 years of work, and there is a tumor heterogeneity. Even a single tumor, we say there is enormous heterogeneity. It is not the same in different people. Same. So as a result of providing the same treatment for a same organ or tumor like a breast tumor or lung or prostate, it doesn't mean that all are going to respond same in this group of patients. So they are affecting it differently in different ways. So this comes as a say, this is the basic evolution that the best thing happens in the lung cancer. Earlier you only say a patient has a lung cancer. Thereafter we started saying no, it's a squamous cancer or a small cell lung cancer or a non-small cell. Then they come adenocarcinoma, squamous carcinoma. And now it's the molecular generation for the lung cancer, which we say it's a large cell carcinoma, small, and there are multiple mutations. We say EGFR, KRAS, ALK, and for every mutation you count on, there is a different drug which is there. And now the survival has clearly in the, when I have joined oncology in the year something around 2013, at that time the lung cancer outcome is still poor. We have only chemotherapies and the patient goes on for 6 months to 12 months. Now, with any mutation, if you talk about EGFR, the life goes to 3 years. With ALK, the life goes to 7 or 8 years. Even with our different mutation, ROS1 going life to 4 years or 5 years, these group of patients. And there are multiple mutations, so we have to just find out the mutation and treat those target. And that is important, and the survival is increasing in this group of patients. So, but the most important challenge in this field is how you are going to identify these driver mutations. So, what is the basic tool we have got is the ISC initially. From the basic biopsy, there came the role of ISC with different immunohistochemistry we used to find out different mutations. From there onward, we move on to the role of PCR or sequencing techniques which come out, and that is funding the things, or the FISH technique. The latest in this addition, which has already been discussed in the previous talk, is about the role of NGS. NGS is nothing, it's a next generation sequencing. It is a multi-parallel, I'll say a PCR, there are multiples which are going on at the same time, and this surely discovers what is the mutation which is going on and how we are going to treat those mutations. But the problem also comes here when sometimes we are not able to find tissue in a patient. So the biopsy is a difficult thing. In that case, the recent technology which is now coming up is the liquid biopsy. Liquid biopsy is nothing different. It is just you are taking the blood of the patient, and on that blood we are doing those NGS testing or the different testings platforms like digital PCR or beaming methods, and by those we are going to find out that how is there in mutation is that. But still this technology is evolving. If it is positive, well and good, we can treat the patient based on that. But if it is negative, then again we have to go back to find a tissue and then going to test those patients in this group of patients. So as I say, there are many barriers. Tissue acquisition is the most important time. The second thing is the turnaround time, we say. The NGS test takes something around 3 to 4 weeks to come. Even in the best lab, it may go, if there is a high turnover, you may go 2 to 3 weeks. So you have to counsel the patient, if he is not sick, to wait for that period so that we can have the reports and then we can start treatment. We can just follow up. Because cancer doesn't develop in a day. It takes something around months to develop. The third thing is about, we say, is the payment and the cost. So the cost, initially when it was started, the test costs around lakhs. Now it has come to the thousands. Basically it's within 10,000, 20,000 we are even giving, and the limited panels we can also get at 5,000-6,000 nowadays. So these things are coming up as the technology is advancing. We are getting this cost also cut in these group of patients. So just have a little word about this liquid biopsy, which is the recent modulation and now which is commonly also being used if we are not able to get a tissue in the patients. So we test 3 things in this liquid biopsy. That is the cell-free DNA, circulating tumor DNA, or the germline pattern in this. So all these things comes from the either tumor cells or from the healthy cells. And from there we extract out and we do that sequencing and find out what mutation a patient is having in this group of patients. So for everybody, there are 2 trials, I think. So for any medical fraternity should now know that there are 2 type of trials for precision medicine, which is umbrella trial or basket trial. Because I'll say, as I already discussed in previous trials, that aging is one of the most common thing for cancer and the most common cause for cancer. So with age, something around it will be surely like that 1 out of 8 people will going to develop cancer in their lifetime if they are going to live long. So it is, everybody should know how they are going to be treated and what are going to happen. Umbrella trial is the trial which has taken that if you take a particular cancer and you do all the genomic sequencing on that cancer and find out what are the mutations in that, and then you are going to target that mutation. Even they are take for the phase 1 and phase 2 drug delivery is also being, drug development starts also based on this trial. Whereas the basket trial, in the basket trial they have taken all the cancers and they have targeted only one mutation, and they see whether that mutation being targeted to a cancer. If we take a EGFR mutation and we take a lung cancer, colon cancer, or different cancers, and we give the drug for EGFR and all this, it will behave differently in different. But still we can have a, we can see that how it can work. So the personalized medicine surely depends on the right medicine for the right patient and also the time, right time. Because cancer is also a dynamic disease, I'll say. The cancer you have today, after 1 year, it will going to change its biology. And you have to find out at that time again what is the changes is going to happen, and you have to treat differently at that time. So few cancers, though they don't change, but in few there is a definite change which happens throughout. So there comes in, I think, so this precision medicine concept was given in the year 2008, and later on in the year 2015, Barack Obama also make this initiative on precision medicine to, especially for cancer and diabetes, and to create all the, basically they have to join all the experts from medicine, science, technology, because they have to accumulate the data. The most important thing is all the data has to be accumulated in these group of patients, and that has to be used and to create a protocol or a software or the treatment or the drug delivery for the individual patients in these things. Thereafter, I'll say the most common thing which is nowadays in clinical practice is the immunotherapy, which has come in picture. So this immunotherapy is different from cytotoxic chemotherapy in the way only that it modulates your immune system to kill the cancer cells. It is just acting on your immune system, modulating it and helping you to kill. And the good thing about this immunotherapy, the bad thing is that we don't know in which patient is going to work. To giving a data, it is just 20% of the patient whom you are giving the therapy, this is going to work. Though the therapy costs around lakhs rupees, but it is only going to work in 1 out of 5 patients. But the beauty is that if it works in that one patient, the patient is having a long response. He is going to live long. Means we have at least 20 to 30% long-term survival with immunotherapy if they are responding to this drug. So how to, in which patient we get? There is only one approval, the PDL1 which was talked in earlier talk, but the MSI, the mismatch repair or microsatellite instability is the thing. This is basically what we have studied in standard 12, that there is a, during the growth of the any cell, we have to see there is some repair mechanism is there, and if this repair mechanism is got deranged, in that case a cancer may develop. But this is the cancer which responds the most best to immunotherapy. So any cancer, if they have got MSI high, we say this is going to respond to the immunotherapy to this patient. So for precision medicine, we will have, just to sum up, we will say that it has started from the HUGO project in as earlier in the 80s, and therefore the breast cancer project. And now we have in almost all the cancers, we have got different mutations profile which we are seeing, and the standard treatment which was initially chemotherapy has now changed over to personalized treatment. So every person, every tumor, I will say, is a different thing in this group of patients. So how we are treating in our center, how personalized we are doing. So the tumor board is the initial thing which we have established here. In any, I will say, onco center, this is the thing where the surgical oncologist, gynec oncologist, breast oncologist, neurosurgeons, head neck surgeon, or all surgeons come together along with the radiation oncologist, medical oncologist, radiologist, nuclear medicine, pathologist, dietitians, physiotherapists. The most common component is important is the social worker and the coordinators in our team, which helps us coordinating all and the social workers to maintain that the patient is compliant to our treatment. So all this comes in picture, and they take the part of the tumor board, and then we decide about a treatment of a single patient. So we just don't, it is not based on a single person decision how to treat. It's a combined decision which we have to take care to develop all these cases. Molecular tumor board, which is now the norm for the precision oncology clinic which we say. So it's still, to be physical, it is a tough thing because the important people which we are involved in this are the geneticists, bioinformatic peoples. The others are, I'll say, molecular biologists, pharmacists, and it is a pan-India, or we'll say pan-Asia molecular tumor board. Also, we are doing a weekly molecular tumor board. So any NGS report which comes, because in a next gene sequencing is a testing something around 500 genes depending on the panel we are doing. So we don't know how this is going to work in a particular patient. So for those, there is basically we run a tumor board, we discuss these cases, we take the help of our bioinformatics, geneticists, and the molecular pathologists. And then we make a decision how to treat that patient. And at present, we are doing it virtually with many people, pan-India or pan-Asia also from Singapore or other peoples. For genomic testing, the important thing which we see in that, the NGS report which we see, with whether it's a single gene mutation, multiple gene mutation, the important thing is many labs now are coming with this NGS. But which lab is good, which is not, and which is approved, we have to take that robustness and validity of the data has to be done in those things. Further, the sample type we have to test, and what is the alteration we are going to see. And all these things are fed in the bioinformatics, the computer system. That is, which is a Cosmic, My Cancer Genome, Civic, which we are using and putting those data and see how these patients are going to respond in this group of patients. So, Dr. Rajiv has already has discussed about endometrial cancer. There are multiple markers, ER, PR, MSI, HER2, breast, multiple markers, further oncotype DX and BRCA1 and 2 testing, colon, all RAS, MSI, HER2, BRAF. These are what I have shown here are all those for which treatment is available today, and we are treating patient based on this. So we have to treat every cancer differently based on these tumor markers in these patients of the patient. And now the future is coming even in the cancer screening also. In the cancer screening too, if we are taking a blood of the patient and we are screening for colorectal cancer or others, so the study is going on and we can have, even without doing colonoscopy, we can find out whether the patient is able to develop a cancer or not. But dealing with cancer is not just dealing with cancer, it is treating the whole person. That already Dr. Amrinder has highlighted. That before that, we have the humanization of the medicine has to be done. We cannot just say a patient that we have tested your 255 genes and what to do with that. So we have to see from the eyes of a patient, we have to go to their level to explain them what we are exactly going to achieve from that testings. So we have an individual relationship has to be established on the physician and the medical team. So with this is our, sorry, surgical oncology, medical oncology. So this is the team of our oncologists. The people missing here are nuclear medicine people, radiation people, radiologists and the pathologists. We haven't any photo. And this is our care which we are providing at Medanta at present with all chemotherapy and other drugs which we are giving with our team. Thank you.
Thank you, Dr. Amit. That was a very elaborate presentation. To summarize it, we can say that precision treatment is just personalizing the treatment, because nowadays we have a array of data of human genome and mutations in it. So based on that, what we are doing is what he has said. What we are doing is we are selecting right drug for right patient to give in right dose at right time, and that is what it is all about. Thank you. It was a nice presentation.
Dr. Amit, you have taken us to a futuristic world of Disneyland, and quite
practice,
hopeful.
Sir.
Yes,
it's
but
the practice which is being done nowadays also. It's
no,
not
yes,
like that.
lots of things are already in practice right now, and in future things will improve.
Will improve.
But when you started with the history of the genesis of cancer, let us remember that every day, every person's body, their mutant cells are being produced, but they are being managed by the body, the self-immunity for which you later on talked of targeted therapy and immunotherapy. So let us focus from there, starts from there, how the body killed that cell. Similarly, if the lifestyle is taken into consideration, lots of disease can be controlled, because finally your slide showed that it is the patient's body which finally takes the decision. Because I have seen all, whatever you say, the targeted chemotherapy in lung cancer, EGFR positive, no response to targeted therapy. So it is not mathematics, medical science is not mathematics.
That's true.
However, you have so nicely narrated everything, the importance of NGL, the PDL and liquid biopsy, and the view, look forward 30-40 years also, back, there were many things for us to look forward, but still the cancer incidence is increasing, as Dr. Rajiv Ranjan Prasad has said. Of course, the quality of the patient might have improved. Few patients' cure rate has improved, but overall scenario in the world has not improved. So,
I will not agree with that, sir. So for cancer, I will surely say we haven't cured. For cure, only 2 or 3 cancers are there for which we say we cure them. But quality of life definitely have improved, and their survival, especially if we say if a patient is in 40s and 50s, we can give them 4 to 5 years for them having a good quality of life. We are not curing them. I am surely saying that.
Absolutely, that is what I want to state. I want to say that how the body killed the first cell, similarly your immunotherapy and targeted chemotherapy, how far they will be successful, but they are the future hope for the cancer patients. Thank you very much.
So it was an excellent presentation. And regarding gynecology, I think many of our patients do survive the whole life, like carcinoma cervix if diagnosed early. And now with the introduction of TCGA classification in endometrial carcinoma, the precision medicine is very much into vogue in the management of endometrial carcinoma. So that's a good thing that is coming up with least damage to the patient, and the disease is cured to a great extent. So precision medicine is going to be the future of the medicine. And regarding this NGA, it is very good if you collect the data of the whole world. I think gradually we will be more aware about which type of NGA sequencing is related to which disease, and how can we confirm that what type. Still the data is being in the process of being analyzed and collected. So it was a very good, and it is an eye-opener for a general person who is not dealing with so much with oncology and this genomic classifications and all that.
Thank you. Thank you very much for your presentation. It was in a very wonderful way you have show how to plan a patient for cancer patients. So we must agree the 3 P's are very important: the precise treatment, and personalized care, and the purposeful, with the time and dose. Thank you very much for your.
Dr. B.C. Khandelwal. I'd request the chairpersons to kindly have a seat as well. Dr. Ravi Biaro. But please have a seat. You'll have to take it in a chair conversation. Last and final session. Last and final session. Dr. Ravi Biaro. Dr. Sanjeev. It's okay. It's okay. Any time off on the Sunday will be the best. That's okay. I really just go to and of course, last but not the least, the speaker, Dr. Amit. Last and final talk, that's to be delivered by Dr. Sandeep. And can I request Dr. Sanyal to kindly come up on the stage? Sir, you'll be the chairperson.
Dr. Latham, I'm supposed to serve this with you during the session, so please ask. And of course, Lillian, Dr. Latham, please, the man will see this. So, please.
रेगुलेट नहीं करे तो ऐसे भाग कर जाएगा. Please invite Dr. Khandelwal sir and Dr. VP Singh sir, please. And Dr. VP Singh.
You've got two chairs. Dr. VP Singh sir, please.
And Dr. Khandelwal, please.
And Dr. Khandelwal, you'll have to take the.
See, I have to hold them back, so if I don't ask them to chair the session, I don't think anyone is going to stay back.
Please, सर आप इधर आ जाइए, इनको कंपनी दे दीजिए. Please give him company. Yeah, please.
And Dr. Deepak also, please. Dr. Dinesh sir, please call Dr. Dinesh sir also on the session. One second, ma'am. Thank you, ma'am, for the kind introduction. I'm very thankful that you're still here in the hall, and I would like to finish it up in a short while. Thank you for bearing with me. So, my slides are there. Can I have a pointer, please? Yes. So I shall be talking about recent advances in the management of pancreatic cancer. This is a broad topic. Why are we dealing with this cancer? Although it's not that common cancer, but if you notice, this is the fourth leading cause of cancer mortality in the Western world, and seventh overall. And in India also, the prevalence has started to pick up, and it is around one in every 40,000 person are known to harbor this cancer. There is slight sex predilection for the males, and the problem scenario is that almost 50% of these patients they have metastatic, they present at the stage 4, and only 10 to 20% are resectable. And the dismal prognosis can be understood that most of them will recur in a period of over 1 to 2 years after resection. If we talk about the risk factors, I'll just go through the common risk factors. That's smoking, obesity, heavy alcohol consumption. But the two important ones are recent onset diabetes, and the other one is familial risk factor, along with chronic pancreatitis. Now there are certain syndromes which are linked with this. They are mainly inherited pancreatitis, Peutz-Jeghers syndrome, and hereditary breast and ovarian cancer. And first degree relatives, as the number of first degree relatives increase, the risk of cancer increases manifold. Now, if you talk about the pathology, what I want to say that we will talk only about the adenocarcinomas, which form the majority of these tumors. What has come up in the latest, in the last few years, is the tumor microenvironment, And these patients, these tumor has, there's an abundant hypovascular stroma with an scattered, widely dispersed tumor cells. And most of these will have a high PNI rate, and they are tolerant to nutrient deprivation. So this harsh environment leads to picking up of those clone of cells which are very resistant to therapy. So presentation is, if it's a head pancreas tumor, it's mainly jaundice, and for body and tail tumors, weight loss and abdominal pain. But two important symptoms which I would like to highlight is a new onset or a worsening diabetes, especially in elderly patients more than 50 and who develop and are non-obese, and they develop an insulin dependent diabetes. One should think of it, and 1 in every 100 of such patients may harbor a pancreatic cancer. Another interesting symptom is a new onset depression in 40% of these patients. Now workup is will involve a liver function test and CA 19.9, which is a tumor marker. But CT scan, there is a special type called triphagic pancreatic protocol CT scan, where the water is used as an oral contrast, and high concentration iodinated IV contrast is used. And these scans have preferably sub-millimeter scans, less than a millimeter section should be taken, and with a good CT scan, that's at least a 64-row scanner. And images are required at arterial, parenchymal and portal venous phase. So what happens in this sequence is that the tumor relation with the vessels is best delineated, especially the SMB, PV, portal vein, and supramesenteric artery. Also, lymph node and distal metastasis can be better picked up. Now, if you talk of EUS, the endoscopic ultrasound, the role is mainly for very small tumors where CT cannot detect them, or for taking a guided FNAC or a biopsy, or knowing relation with the vessels. Now, role of PET CT scan is for patients who have high risk features like high CA 19.9 level, or a large primary tumor, or large bulky nodes where there are chances of a distal metastasis. And second is staging laparoscopy. This is also has been found to prevent a negative laparotomy in around 1/4 of patients when the tumor is of high risk. So what do we do? What we get in laparoscopy through staging laparoscopy is that we may detect small liver metastasis or peritoneal nodules. ERCP and biliary stenting is mostly used for patients who develop cholangitis or a coagulopathy, or have a bilirubin more than 20 milligram per dl, and this will prevent liver failure, or it may lead to a poor outcome if they are taken up upfront for surgery. Preoperative biopsy is unlike other tumors. Generally, a biopsy is not required when we are dealing with a case of with a solid tumor, and this clinical suspicion is high. It's only required when we want to give neoadjuvant therapy to these patients. Now, staging is, as for other tumors, the TNM staging is used. The T stage is T1 to T3 is from based on the size criteria, that is less than 2 to 4 or more than 4 centimeter. Now, stage 2B is important now because here the nodes get involved. That's the N1 disease is there, and another is stage 3, which is also important because these T4 tumors, now they tend to involve the arteries. Now, mind you, the veins involvement is not is taken under the T4 disease. It's only the arteries that are involved in that vicinity. Stage 4 is metastatic disease. Now, we need to classify pancreatic tumor before going for any form of therapy. So the tumors are either resectable, borderline resectable, locally advanced, or metastatic. Now, how do we do that? So for resectable tumors, the tumor, the contact with the vein should be less than 180 degree, or there should be no contact, and our arteries are always free. For borderline resectable tumors, the contact with the vein or occlusion is more than 80 degree, but they have to be reconstructible, and the contact with the artery should be less than 180 degree. But for locally advanced tumors, there's a contact more with the veins, but they are not reconstructible, and with the artery it is the contact degree of contact is more than 180 degree. So here on the CT scan you can see this on the left hand side, the tumor mass which is hypodense,
is quite separate from the supramedullary vein and artery. While on the other, the right hand side picture, you can see that the tumor is abutting the supramedullary artery, but it's less than 180 degree. So that makes it borderline resectable. So two new concepts have come in terms of resectability. One is the biology of the tumor that we need to understand. Why? Because if any patient has a CA 19.9, which is more than 1000, and or a biopsy proven or PET scan detectable nodes, these are the patients where you may have, these are suspicious of having a metastasis. So for these patients, an upfront surgery may not be a good option, or even though they may be resectable on a scan. And the other thing is conditional staging, which which includes a patient who are more than 80 years of age, but have a marginal performance or any comorbidity which can be corrected, but they need time. So the new concept of a neoadjuvant therapy for potentially resectable tumors. The advantage is that you can complete the multimodal therapy for these patients. But the flip side is that there's a risk of progression if you continue with chemotherapy. And another thing is EOS guided FNA related complications can occur. So there have been many RCTs, but we show that there has been improved RGO resection rate or pathological response, good pathological response, but there's been no change in the improvement in the median overall survival for the resectable tumors. So that's why neoadjuvant therapy is not the standard of care as of now for resectable tumors. Now, talking about the minimal invasive surgery for resectable tumors, it has been well established for distal pancreatic tumors, where a laparoscopic distal pancreatic splenectomy has been found to lead to less bleeding and faster functional recovery. I mean, you get at least 2 days of early recovery through laparoscopic surgery. But for the head pancreas tumors, the mortality was found to be higher, so that was abandoned. It was stopped early, this trial called the Leopard 2 trial. But with the advent of robotic pancreatic duodenectomy, there have been new hopes in this field. Why? Because robotic offers better magnification, precision, better dexterity, better degree of freedom of movement, and better ergonomics, and also good RGO resection rates and lymph node yield. However, the operating time is a bit higher. So what do you do for these resectable tumor? Traditionally, we know we operate and we do a Whipple surgery, which is a very famous surgery where we resect. It's a big surgery, major one, where we resect the tumor in the head of the pancreas here, along with the loop of duodenum, distal stomach, proximal jejunum, and CBD along with the gallbladder. So one of the patients where this was operated, you can see here that after resection, the entire vein, starting from the SMB, PV, gets exposed, and this is the cut end of the pancreas. The CBD is been cut here, and we have brought the loop of jejunum into the supracholic compartment for the anastomosis. Now, so this is how it looks after the reconstruction. Pancreatic end to side pancreaticojejunostomy with a hepaticojejunostomy has been done. And important thing is that all such anastomosis have to be tensionless and done with proper sutures, very fine sutures. We should take care of the hemostasis, and this will lead to a less complication rate. And these surgical improvements have decreased the morbidity rates in the recent years. Now, talking about the pancreatic body and tail tumors, a distal pancreatic splenectomy is the surgical thing. A modification by Strasberg called the RAMS procedure, that's a radical antegrade modular pancreatic surgery, gives a better tangential margin and a higher lymph node count. There has been standardized complications defined by the ISGPS, or the International Study Group of Pancreatic Surgeons, and which define the mortality has come down to less than 3% in all good centers of the world. And talking about the morbidity, although it is nearly 40 to 50% will have some sort of morbidity, but with good surgical techniques, these mortalities become, the severity of these mortalities have come down to to less than 10 to 15%. Now, pancreatic cancer, we need to understand, just like breast cancer is a systemic disease. So all resectable pancreatic cancer, irrespective of T and N stage, will require an adjuvant chemotherapy, and that has to be started within 12 weeks. And generally, gemcitabine or fluoropyrimidine based chemotherapy has to be given. So there have been multiple trials over the years, and what we see is that there has been a progression from a single agent chemotherapy to multiple agent chemotherapies. And you can see the median overall survival has gone up from 24 months to now, through the PRODIGE trial, you can see it has gone up to 54.4 months, and this was published in New England Journal of Medicine. But the only criticism that was done, that these patients had were very carefully selected, and they had an ECOG score of 0 to 1. But yes, the survivals have definitely improved drastically. Now, talking about the second type of the tumors, they are called borderline resectable pancreatic cancers. All these tumors, they need to undergo FNA to prove the disease, and then most of them will require stenting. And the treatment begins with some form of a neoadjuvant therapy with a chemo or a chemoradiation following an induction chemotherapy. So FOLFIRINOX is again it's a good option, with showing very good R0 resection rates to the tune of 80 to 90%, and that's very good for a borderline resectable tumor. Few randomized controlled trials, PRIOPANC, which is there was subgroup analysis done. It was actually for the resectable tumors also, but there we didn't get any median overall survival advantage. But for the borderline resectable tumors, we have a definite improved overall survival. So what has changed over the years in surgery? So the approach now is an artery first approach. There are multiple techniques through which we do it, but now we need to hit the artery first, that is the superior mesenteric artery, and then we decide then where to then put the line of resection, whether we go to the right of the SMV or in between the SMV or SMA, or we go in the subadventitial plane of the artery. So this is one of our patients where you can see the tumor is involving the superior mesenteric vein, and we have defined superior mesenteric artery to the left, you can see. So we take control, and we try to hang the tumor on the SMV, and that part has been resected, that is resected, and along with the tumor, and then we anastomose the vein through fine sutures. Now, interesting thing is that this resection has not changed the mortality, and the mortality morbidity are almost equal to what we do for resectable tumors. Now, talking about the management of locally advanced pancreatic ductal adenocarcinomas, these patients, they as the name suggests, they pancreatic cancer, and that also locally advanced. That is they must be very aggressive. But for with the if we have to be very selective for treating these patients, and induction chemotherapy works wonders for these patients. And see, up to more than 50% of these patients can undergo successful pancreatectomy with 90% R0 resection rate if we carefully choose these patients. Now, one interesting fact which I want to highlight is that, see, only 30% of the patients will undergo a radiological downstaging, even with very good chemotherapy. But I mean, 70% will be radiological stable. But still, nearly more than half can be resected with 50%, with 90% R0 resection, which is very interesting. Obviously, these are major resections, and will lead to high mortality rate. So, one of these is to reduce the mortality, the morbidity. One surgical innovation is a divestment of superior mesenteric artery, where we go in the subadventitial plane. Like you can see here, we go in the subadventitial plane and dissecting out the tumor along with the adventitia of superior mesenteric artery. talking about the metastatic disease, with a lot of progress seen in the chemotherapy, the median overall survival, even for this group of patients, have increased from bare 4 to 6 months to around 1 year. I mean 8 months to 12 years, 12 months. That through use of gemcitabine based or combination or a FOLFIRINOX. Now, precision therapy, as Dr. Amit was speaking of, does have a role in pancreatic cancers also. We can see that BRCA is one mutation where you can use PARP inhibitors. MSI high patients can undergo PD-1 use of PD-1 inhibitors, or an NTRK mutation can be also be treated. However, these mutations are less than 5%. So that forms a very small amount of these patients. So to conclude, pancreatic cancer is a systemic disease, and but yet with the use of multidisciplinary treatment, chemo and chemoradiation, the survival has improved drastically, both disease-free and overall. But surgery done at the right time by an experienced surgeon holds the best chance, gives the patient the best chance for survival. But the aim of surgery has to be an arterial resection. The interesting fact, as I told, is the role of neoadjuvant treatment in resectable tumors and use of aggressive surgery following induction therapy for locally advanced tumors, which have given excellent results. And minimally invasive therapy, mainly through robotic or precision therapy, which we have now, is the way ahead. And with this, I would like to end up my speech. Thank you so much for your patience. Please.
Very nice presentation.
Thank you, sir. Thank you, sir.
It's a very difficult disease.
Yes, sir.
You know, pancreatic cancer, that is the main crux. And surgery is the treatment of choice. There is no other things are adjuvant. This presentation depends upon the location of the tumor, whether it is head of the pancreas, body of the pancreas, or tail of the pancreas. When it comes to the head of the pancreas, the symptoms will quicker. Probably you can diagnose early. But in the body and tail portion, they come with big mass. This is our legal behavior. The success of surgery very difficult.
Yes, sir.
The adjuvant treatment or chemotherapy or immunotherapy or target therapy probably given some cleavage on the surgical skill.
Yes,
But surgery remains the main treatment of choice. But early diagnosis, a suspicion of diagnosis with the vague symptoms, abdominal discomfort or indigestion, one must think of pancreatic cancer.
Sir.
So this is my remark, and probably another thing which has happened in the transplant of the pancreatic transplant, when the
Total pancreatic, yes.
So that you can improve the quality of life. Thank you very much for my presentation.
Thank you so much, sir.
Thank you, Dr. Sandeep, for a nice review of the whole
it was
part of pancreatic malignancy. Yes, I will allow. But I would like to make a little longer comment. Firstly, whenever we talk of pancreatic malignancy, we are quoting mostly from Western figure, and even you have not mentioned what is your experience or background. We just don't want to listen the bookish things. For example, I have done almost 200 cases of Whipple. 95% of them are periambulatory, which is the cases that we see where there is no question of portal vein involvement or artery involvement. However, cases of pancreatic head tumor are also common. One or two things you have nicely covered everything, but bilirubin per se 20 milligram, for me it is not acceptable. If the patient's other parameters are normal, we don't just biliary drain since bilirubin is more than 20. Of course, the other things that you mentioned, that cholangitis, of course no one would operate if the patient had cholangitis. Similarly, the time was there when people used to say that even without tissue diagnosis you can go ahead. Now the EUS is there, which can pick up. Of course, if the repeated endoscopic ultrasound doesn't diagnose, but one should still try, because it is a very morbid and high risk cases, and the mortality, even today, general surgeon don't touch pancreas. Just those who are not oncosurgeon or GI surgeon, they know that general surgeons will not touch the pancreas. It is still untouchable. even those who were expert, the mortality rate was very high, up to 10% earlier. But now it has come down to less than 3%. And when more and more experience, like you have such a vast experience, VP Singh has, so the incidence of mortality has reduced. In spite of that, pancreatic surgery is a very difficult surgery. Yes, please.
There is a question over here.
I just want to comment, sir.
Okay, please go ahead with the question.
Thank you, Dr.
Sir.
Sandeep, for the nice deliberation. Just out of query, with respect to what I have seen in my residency days in the wards, that a patient of Whipple's surgery who's undergone hepatococcygeostomy, gastrojejunostomy, jejunojejunostomy, I have seen many patients in the ward 2 weeks, 3 weeks, 4 weeks running with the nasogastric tube on, walking around. So gastroparesis was a very big deal for those kind of patients.
Correct, sir.
So has the scenario changed within the last 20 years, or it's almost the same? Thank you.
Sir, it has come down definitely, but still it is seen in 20 to 25% of patients. Now, what surgical modification we have done is, now we go for an anticolic gastrojejunostomy, and if we combine with a Brown anastomosis, that between the afferent and efferent loops, if we combine those, then you can bring down that the distal delayed gastric emptying. Second thing is, besides this pancreatic, pylorus preserving type of resection has been shown to have a higher chances of delayed gastric emptying. So now most of the surgeons, they opt for either the classical type, but little bit of less of antrum resection, and second, or they go for a pylorus resecting type to prevent that complication. And my comment on sir, he is very right. Sir is rightly said that it's a difficult surgery, and most of it, these my experience, I would say, sir, for the last 10 or 11 years I've been working in high volume centers, and as the experience increase and with the use of better magnification, or with good use of fine sutures, the morbidity has really come down. So experience does play a good role for these cancer patients. And second thing about the cytology or the diagnosis to be made early is, sir, you are right, that's a very major morbid procedure, and we should take a FNA. But the problem is that if you go for FNA in these sessions, they may land up with some form of a complication of pancreatitis, and 90 to 95% of tumor in this location has been known to have a malignant disease. Only 6% chance, it's a proven fact, with that these patients will have a benign disease on final histopathology. So the dictum is that you don't need to do and it's a medical legally safe also, sir.
Yeah. In fact, any tumor in the pancreas, surgery is the main modality of treatment. Biopsy or no biopsy, you have to go ahead with a surgical procedure. Another point I would like to ask you, how conversant are you with portal vein resection, and do you do the resection anastomosis yourself, or do you require a plastic help in that?
Sir, I have done 3 till now. Whipples have done, I don't remember the numbers, but we used to do a lot during our residency also. But portal vein resection myself, I've done only 3. And one patient landed up with a portal vein thrombus, and we had to re-explore that patient.
So, do you take any plastic help or any vascular help?
Initially we used to do it with the help of plastic surgeons.
Have you resected, length more than, or you have to put some graft in it? Have you tried that?
Sir, graft can be done, but usually if the length of resection is not more than 3 centimeter, you can easily bring them together, provided you've done the mobilization.
Up to 6 centimeter one can manage.
Yes, sir, you're right. I agree. But for mediocre surgeons like me, I think 3 is good enough. And if you mobilize go for a good mobilization, that becomes easier.
And will size be a constraint for you? More than 4 centimeter, will you be again comfortable in going ahead with, or would you curtail yourself to head not involving the superior mesentery, given the size is more? Size will be a constraint for you or not?
Yes, size and location both does matter. Like the tumors of head going to the uncinate, they are always going to be a difficult, and so especially for these tumors, you need to go for an SMA approach, SMA first approach.
Dr. Sanjeev, some question from you.
Yeah, during the last 1 month, I've been closely associated. I closely see these procedures in our center. The gastrosurgeons in last 3 months did 3 cases, and in all 3 cases they have called us as a CTVA surgeon for portal venous anastomosis. So initially they have some problem in dissection. Then
yes, sir, it happens.
As you were discussing, the length was short, so we could do it. In 1 case, out of 3, 1 case we have to re-explore in the middle of the night of the thrombus, but it did come out well. So my curiosity is one thing: if the pancreatic cancer is resectable,
sir,
you are able to resect is early phase of cancer, is there any role of pancreatic transplant in this case?
For total pancreatic cases, sir, we need to do it for total pancreatic, but my experience is very less, sir. I have seen only 2 total pancreatic cases till now in my 11 years of experience in thrombosurgery.
In the case of pancreatic transplant is different.
Sir, maybe
I understand.
You are talking of pancreatic transplant.
Transplant for early cancers.
For early cancer.
Is there any indication or can do it?
No, sir, not.
No. Even total pancreatectomy has been done in Western world. Total pancreatectomy without any supplement. But then, of course, external supplement has to be given. It was so much, morbidity was so much that now no one advocates total pancreatectomy. But pancreatic transplant is done for diabetes, for other purposes, that is separate.
So I remember a patient while I was in BHU that a young lady was operated for this Whipple's, extensive disease in the neck region and with nodes going up to the splenic hilum where we had done this. But managing the patient in the post-op period became very difficult task with lots of fluctuation in glucose level. So it's a difficult thing, especially the post-op is very stormy. Post-op is very strong. And sir, you rightly mentioned for longer involvement of SMB, I had one case where we called the plastic surgeon. I harvested the internal jugular vein for them, and they did the resection.
We can put a graft also.
Yes, we can. IJV we have used.
But they call, as a CTVA surgeon, they usually call us.
So we asked, we call for CTVS surgeons when we also panic. You are the last resort for all of us.
Saviors,
rather. Saviors, yes, sir. Yes, ma'am. In the post-operative period, you are asking now? Ma'am, we do it routinely. It has to be done. Prophylactic measures have to be taken. After, personally I start the next day, but it is a routine, ma'am. For all major cases lasting more than 6 hours or pelvic cases or a lower limb malignancy, it has to be done.
But
no, I have no experience. Sorry.
Blood flow has to be checked within 48 hours.
I think for any oncology surgeries, if the surgery lasts, if you are expecting that the duration of surgery is more than 6 hours, prophylactic thromboprophylaxis has to be given.
No.
And that starts.
No, ma'am's question was different. I also misunderstood. See, do you?
Yeah.
You're right.
But
I believe there is a score called Khurana score. We calculate for every patient having pancreatic or those cancers who are having high risk of thromboembolism. If Khurana score is more than 3, we shall start prophylactic. Otherwise, it's not required.
So, Dr. Sandeep, it was a very comprehensive overview of the pancreatic cancer. It was such a lucid presentation. But just a comment, if you look at the scenario which we get, it's mostly the locally advanced cases which we are facing. And in spite of all the radical surgeries and chemotherapy, loco-regional failure is the pattern of failure.
Correct.
So, I think that another local therapy which we have is the radiation therapy, and especially with the conventional, the ASPAC trials and all, they have shown that conventional radiotherapy is not very effective. But now with the advent requirement of SBRT, maybe because these tumors are radio resistant. So if we increase the dose per fraction, just as per the biology of the tumor, the alpha beta ratios, now we are going more for hypofractionated, increasing the dose per fraction. So maybe we can have the SBRTs, some of the recent trials, they have shown an advantage, and maybe in future we can combine SBRT with chemotherapy in the neoadjuvant setting and get,
I don't know whether I should comment on this or not, but I was going through, I have little knowledge about radiation, especially the various aspects. But what I read is that probably they did a research in the Massachusetts General Hospital where they used SBRT and HIGRT, that was hyperfractionated image guided radiation therapy. And the results when compared to EBRT or MRI gated radiotherapy, I mean MRI linked with line, which what I understood, through which you can give up to 100 grays of radiation over a period of 7 weeks, or an IMRT, those have been shown to have a better result than compared to SBRT or HIGRT. But
it's actually, when we talk about radiotherapy, it's the biologically effective dose, and that you can happen, and that you can increase the BED either by giving large dose per fraction. Another advantage with SBRT is that there is no problem of timing. It can be combined with neoadjuvant chemotherapy. Week 1, 2 and 3 you give gemcitabine, and week 4 you give SBRT, 25 to 30 gray in 5 fractions. So the schedule, the most important thing, which is the chemotherapy, because if we are taking it as a systemic disease, the chemotherapy is important. So the SBRT, the timing is very important, and it is not going to disturb your regular chemotherapy and surgery, the timing, the protocol.
Yes, ma'am. Chemoradiation has a major role, I mean, at least for the borderline resectable cases. It is
Dr. Rajiv has some comment. Dr. Rajiv, you want to make some comment, I suppose?
Most of the resected case, they fail at the local site, isn't it?
Sir.
About 50 to 80%. So what is being practiced, though it is not very popular, is intraoperative radiotherapy.
Yes,
you give 10 to 20 gray fraction while the incision is there, and you can directly treat. And the results shows that the chances of recurrence decreases, but there is no survival advantage. So
Yes.
this is popularly used in Japanese countries and others. In India also, I think in Chennai they have this facility.
I think you are correct.
Yes.
When there is no SRS, SRT, this was practiced in cardiac cancer center.
Intraoperative
radiotherapy to do in inoperable patient, and surgery cannot be done. They have got a dedicated rear accelerator. From operation theatre, they get the radiation done and then put the abdomen. So that is why you can't do the surgery, proper surgery. Just to reduce the volume, then you give some, it is more of a, what should be the palliation, something like that. So intraoperative operation, it is an old practice, but now with the advent of new technique like ISR, SRT, that thing is a subject of history.
Sir.
They don't do it.
Any further questions from the House, or are we ready to close?
So thank you very much, Dr.
Thank
Sandeep.
you so much for bearing with me and staying back in the hall at 3:30
Yeah.
p.m. I think.
Never
Thank
mind,
you
we've got a Scumptus
It
lunch
was-
awaiting on. Let's get away. So please be seated. I mean, let's get away with the felicitation, and who better than Dr. VP Singh and Dr. Khandelwal to jointly felicitate Dr. Sanyal.
Thank you very much, Dr. Sandeep, for having me on the chair. And thank you, Rajiv sir, for inviting us. Thank you.
Round of applause. Come on, make some noise. Dr. Richa Madhvi. Dr. Richa Chauhan. And finally, the speaker, the last person of the day, Dr. Sandeep. Oh, well, thank you so much, ma'am and sirs. Yeah, sure, why not? Can I request Dr. Ravi Shankar as well, please? Sir, Dr. Rajiv, Dr. Sanjay, sir, please. Ma'am, please come. Dr. Amren, Dr. Rajiv over there, please. The MS over there, Dr. Asif. Yeah, come. The photos are. Yeah, sure. Dr. Ajay Sinha over there, sir, please. Dr. Abhishek, why don't you come up? Come. Sir, can I have you? Have I missed out? Mike? Have I missed out anyone? Have I missed out anyone? Please, ma'am, over there, please. Ma'am, please. Dr. Sujit and ma'am. Dr. Sujit, ma'am, please come. मैं नीचे आ जाता We still have space. The circle can be. Please come. सब आ रहे हैं. वो circle को deep कर. Someone from the center, I'll just go. You just have to show this side. We are done. Pura single. Yes. Pura Yes. Pawanji, are we good? Go ahead.